with all the, and we want to thank you for logging in. As we look at the theme for the World Cancer Day, and really the year to speak, it's closing the care gap. We know that cancer is something that we cannot run away from. In Kenya, it forms one of the third leading causes of morbidity and mortality. And having such sessions and many that are being done countrywide is very key and important in trying to sensitize ourselves to what are the challenges that we have, where have we reached, and where are the opportunities that are available so that we can close the gap. And when we look at closing the care gap, it's really going to be emphasized through all our presenters. We have a wonderful team of various experts in different aspects of cancer care, advocacy experts as well, cancer survivors, because we know that when we speak cancer, we have to have all the stakeholders on the table if we are to make a difference. And so really the clarion call to everyone is what can we do? Who can we have on the table to have this conversation so that we close the gap that is there? And looking at it at our various levels, you know, if we start from a global perspective, regional, country, and then look at the various regions within the country, look at each county, and even down to the facilities where we come from. What are the things that we can do to make sure that each and every patient who gets a diagnosis of cancer has access to care that is affordable and not compromised care, but quality care, so that you can optimize their outcomes dependent on where they are in their cancer journey. So to help us off this morning for the first part of the presentation, we have Dr. Catherine Nyongesa, who's with us. She's a consultant radiation oncologist. I know she's many of the participants would know her. Here at KNH, she's our head of department at the Cancer Treatment Center, and it's a pleasure and an honor to invite her to give us the opening remarks. Karibu sana, Dr. Catherine Nyongesa. And I'll encourage all the participants, if you have any questions and comments, let us use the Q&A in the chat section. Thank you very much.
Thank you so much, all of you, and really very glad to have this day pick up. And I'm just going to give a few remarks, and thank you, Matilda, for the kind introduction. So World Cancer Day, as you've seen, the theme is to close the care gap. And who is behind the World Cancer Day? Well, this was a slogan that was put up by the Union for International Cancer Control in 2000 at the World Summit Against Cancer for the New Millennium in Paris. The theme is Close the Care Gap, and this theme will run from 2022 to 2024. And it really brings out the power of knowledge. Individually, we can make a difference. Together, we can make real progress in reducing the global impact of cancer. The goodness is that all of us, everyone, can support this initiative, and everyone deserves access to cancer care. Play your part in creating a cancer-free world. Closing the gap in cancer care, who are we closing the gap for? So one is the world has greatly advanced in cancer, prevention, diagnosis and treatment, but many are denied basic care. Why? Because of the equity, and this gap costs lives. What are some of the barriers to cancer care? Number one is income, education, geographical location. Many a times we have patients coming from very far and you have to come to Nairobi for treatment. Already that is a geographical barrier. Discrimination, ethnicity, race, on gender basis, age, and even disability. Increased exposure to other risk factors like tobacco, unhealthy diet, or environmental hazards. The gap affects everyone. So ask yourself, am I promoting health equity in my day-to-day roles as a doctor, as a pastor, as a politician, a policymaker, family, cancer activists or advocates, and health financiers? So today we'll hear from all these people on how they are closing the gap. As KNH, we've been trying for many years. Actually, Kenyatta National Hospital Cancer Treatment Center is over 50 years old and it was the pioneer in trying to close the care gap. KNH started with a superficial orthovoltage unit, and then we got cobalt units in 1984. And subsequent years, we've gotten newer machines and replaced older ones. The first LINAC in the country was installed in 2010. And at KNH, we have an Electa machine, which is a linear accelerator. And we also have 2 cobalt units. In terms of capacity building as KNH, in collaboration with the University of Nairobi, we have the radiation oncology training available, and it has picked up very well. There's also nursing oncology, both at KMTC and University of Nairobi. Therapy radiography training, Kenyatta has been a pioneer in collaborating with other universities, just to name JKUAT and University of Nairobi and KMTC, just to have this training. We are going to have the first ever medical physics training program in collaboration with the Technical University. We already have medical oncology fellowship training at University of Nairobi. Gyne oncology training also at University of Nairobi, and I know there's also at Moi teaching referral in collaboration with Moi University. We offer training not only for Kenya, but for the region in trying to close this care gap. As a department in Cancer Treatment Center KNH, we have mentored and nurtured new centers. I'll just name a few: Nyeri County, Meru County Referral Hospital Cancer Center, Mombasa County Hospital Cancer Center, Garissa, Nakuru, and others are signing up for partnerships. On outreach programs, in most counties is done on continuous basis. We do sometimes outreach physically and virtually. Our goal as Kenyatta National Hospital is health equity now. Ask yourself, am I promoting a healthy equity in my day-to-day roles? So today we reflect on all ourselves, and if you are logged in, please reflect on yourself and see how are you contributing to closing this care gap. Thank you very much, and I hope that we all enjoy this day and have a fruitful meeting. Back to you, Chair.
Very much, Dr. Nyongesa, for setting the pace for us. And without taking any more time, I'm going to invite Benda Kithaka. Brenda Kisaka is the Executive Director of Kilele Health, a very passionate advocate for patients. And so, Brenda Kisaka, over to you to share with us what you have for the World Cancer celebrations today. Thank you.
Thank you so much for that invitation, and thank you for the amazing introduction. I'm going to take just about 15 minutes for us to talk about the World Cancer Day and to talk about how we can close the care gap. I'm hoping by the time I'm done with this conversation, all participants present will have an idea of what it is to close the care gap and also take home a few things that we can do in our own individual capacities to close the care gap. A little bit about me. I do a lot of patients advocacy, and from speaking at international platforms, sitting on various technical working groups, as well as locally navigating even patients physically. Yes, I do have a team, but right now we have a patient receiving chemotherapy at Kenyatta Hospital, admitted on Monday, and every day I visit the hospital. Every time I interact with a patient, I see what gaps we have, what opportunities we have to make a difference in the way we practice our care plan so that we can improve for our patients across board. So today, as I speak to you, I sit wearing the hat of an advocate who is with Kilele Health Association, but also later today, I'll be wearing the hat of an advocate globally, speaking on the UICC Close the Care Gap. And so today's focus for me is to just put a teaser out there. What are you doing as an individual? What are you doing as an institution? What can we do as all of us to close the care gap? I hear if you show people photos, they listen to you more keenly. But on this slide, I would want you to focus on where you can get more information about the World Cancer Day and where you can dig deeper, understand deeper from what Dr. Catherine Nyongesa has spoken about the World Cancer Day for you to get more information, because right now we may not be able to cover everything. A little bit about cancer care in Kenya. There are 5 cancers devastating Kenyans. And these are the main causes of cancer mortality, cancer incidence in the country. But did you know that out of all these cancers, about 80% of them are found rather late in the hour? When I say rather late in the hour, the palliative care team will say, it's never too late, there is something we can do. But from a perspective of treatment, better outcomes, better quality of life, late diagnosis does impact the cost of treatment, does impact the outcomes, and does impact how the patient will live beyond the cancer. And that's what we are focused on. Did you also know that according to the WHO, at least a third of all cancers are preventable? We have the vaccines, we have the technologies, we have the capabilities and the human resource capacity to do so. Regrettably, that 1/3 of the cancers are actually the ones that are currently devastating people. Yet can be addressed with lifestyle changes as well as addressing the risk factors. Secondly, did you know another 1/3 can be treated 100%, recovery and better quality of life? The key thing is early detection, timely treatment, post-treatment reintegration to the community. I'm skipping through the slides because there is a lot for us to discuss, but I'll share this slide so that you can be able to look through them. So where are the gaps in cancer care in Kenya? For the healthcare practitioner on this call, we often assume that cancer care starts at the facility, where the diagnosis is done, where the staging is done, where the person sitting across the table has to face you and you have to tell them, hey, you have cancer. Different ways of breaking the news, but it's never often received with the same kind of reaction. Some people react with fear because they are fearing the cost of treatment. They are afraid of what will happen to their family. There is this element of the moment diagnosis is made, there is the concept of that's where the cancer journey starts. But I want to put it to you that as participants here today, cancer care starts in the community. It starts with awareness education for people to be sensitive to the risk factors and to minimize them. It starts at the community with knowledge of personal history for health. People who have a genetic risk disposition ought to be sensitized as early as possible to be well aware of how they can mitigate the risk factors, but also well aware of how they can prevent for themselves, and screening for early timely discovery. Secondly, the gaps start also at the community with fear and stigma. The question is, why do we have a HPV vaccine right now that was started at 10 years old for 10-year-old girls' eligibility, has been extended to 14 years old eligibility, and we are still at 33% uptake? Why? Because fear, stigma, because misconceptions and misperceptions of the vaccine, all which start at the community. Again, the cost of care. Because people fear the cost, they want to, as much as possible, not to be found out. Let's get into the facility. What are the gaps? Overwhelmed healthcare systems, because people presenting late means more effort in curative care as opposed to preventive care. It also means the structures are stretched, because we have only how many care centers in Kenya, all concentrated, majority in town, urban town centers, and mainly for radiotherapy, chemotherapy in Nairobi, the capital city. What that means is majority of the people in the rest of the country have healthcare systems that are stretched, and therefore they're not able to take care of cancer as we ought to. When I speak of the gaps, let's also talk about cancer and how it affects each one of us. You as a medical practitioner, there is always that element of I have to tell someone they have cancer, and that doesn't come easy. And if you have to face so many people, we get about 42,000 diagnoses every year. If only a few doctors are sitting and telling these patients that, what about the mental wellness of the health practitioner themselves? They who have to deal with these issues of late diagnosis. To the patient, to the family, to the caregivers, there is of course the fear of the pain, the fear of stigma, the fear of course, and to the corporates, we are losing manpower and productivity. Generally, there is a fear of cancer perceived as a death sentence. How can we change that? In advocacy, it's one of the things that's most often misunderstood. And I came here to talk about how can we advocate to close the care gap. Politically, we can lobby for impact, for policy. In education, we can lobby so that we provide the adequate information at the community level for prevention. In fundraising, we're able to raise resources. Kenyatta National Hospital, as a referral and research hospital, has the capacity to do research so that we find what is unique to ourselves that may not necessarily be correct with the global data that we get. This informs policy, informs awareness and education, and helps with the better responses to cancer in the country. In community outreach, engaging the community for A, addressing the lifestyle risk factors, B, embracing preventative mechanisms that are available, all this is advocacy. And we often imagine that all these things ought to be removed from ourselves because, hey, we are practicing medicine, the community is the other side. But guess what? When you leave today your work and you get into your public transport or your private transport, the hat you wear that from that moment on changes. You're either a sister, a brother, a cousin, a relative, you're either a community member, you are a parent, you are all these other hats that we wear. So when we think community outreach, it starts with us, even within the facility, the community of practitioners that we are together on. So what is the ideal for advocacy? And I'm just about to finish. We see for researchers that it's very well ordered. We have a trajectory that shows a line across which we can go through to show from community awareness to information materials being disseminated, to primary prevention by vaccinating, to secondary prevention where we are screening, treating, referring, all the way to emotional support, psychosocial support, financial support, advocacy at policy level, and legal rights. But I'll tell you, life is not a straight line. Life is moving from one corner to another, from community awareness to emotional psychosocial support, because the person has broken down in your office. What do? From information and materials sharing, saying you can register for NHIF, and then they say, I don't have a single coin. Where do we get them the financial support for them to be navigated across? From advocacy and policy, we know what the gaps are. As Dr. Nyongesa has spoken and mentioned about Kenyatta's history and the kind of interventions that you've had and the kind of hospital machinery, technologies, and equipments that you have. What about when a machine breaks down and the community is aware? And Benda and her advocates have written in the newspapers to say machines are broken down, what do we do? Who then goes to mitigate the policy to get resources to be allocated to Kenyatta National Hospital? So because of all this, and because we recognize that medical innovations takes years, we recognize we're not working in a straight line, which is from one point to another, moving every time. We ought to think about how do we collaborate to close the care gaps. And with the World Cancer Day, with the UICC, Union for International Cancer Control, there is a 3-year plan. It's not a one-day affair. It's not a one-day campaign. It's 3 years where we're looking at year 1. Let's be deliberate about finding out what are the problems, what are the gaps, what are the ones we are assuming are real gaps, and then let's dig deeper with research. Kenyatta Hospital having a research arm can also drill deeper into research to find out what are the other real gaps that could be mitigated that can help us practice medicine better, practice cancer care better. Secondly, in 2023, we'll be looking at how do we unite our voices and take action. And lastly, in 2024, we'll be looking at together, how do we challenge not just those in power, but also those with capacity to make decisions. Often when we say those in power, we're thinking policymakers, but think about the man in the community as a source of power where he's a determinant of health for his wife who will need to go for screening. How do we ensure that we are empowering communities? How do we ensure that we are impacting our patients, empowering the communities, influencing access to care, and also guiding policy? In these 3 years, we have a task ahead of us. And I have to put it across that we all have a role to play. My question is, how do we start today to build coalitions that will lead for better outcomes for our patients, better outcomes for our communities, and better outcomes for future generations? How do we ensure that girls are getting the vaccine today? Because in 15 years when we are screening, we don't want to find new cases of cancer, cervical cancer that could have been prevented. How do we ensure that men improve on their healthcare seeking behavior so that men at the age of 40 embrace screening for prostate cancer, so that by the age of 60, we're not dealing with invasive metastatic disease? What about women, again, for breast cancer? What about community dietary management for prevention? Lifestyle management, moving more, being more physically active, addressing the risk factors. All these are questions that we ought to ask ourselves. And as I come to the close of my presentation, I showed you earlier today, when I started this slide, the gaps that we see in the healthcare system. The question is, how do we then impact patients? As Kilele Health, we're working with survivors to ensure that we equip them with knowledge, skills, and technical expertise in advocacy so that they become voices of change in the community. Reaching the healthcare system, they already have experienced the healthcare system. They know where it pinches, they know where it hurts. They have lived experience on what has happened in their lives to get to where they are, that they are surviving. Integrating survivorship into the community will mean we bridge the gap at the community because they are real voices. They are more believable. They can show that they have actually survived, and therefore the fear of cancer as a death sentence is no more. Moving on, if you think about it, as Kilele, what we're looking at is not just the physical inspiration for advocacy. We're looking at survivorship as a quality of life issue. We're looking at when they are treated, how do they reintegrate into the community? We are bridging the gaps on interventions, like for screening, for awareness on vaccinations, for awareness on prevention, so that we reduce the numbers that are coming to the facilities to be treated. We're also looking at integration of survivors by putting together financial wellness programs that can reduce the toxicity. Some of the successes, as we challenge perceptions on cancer as a death sentence, as we inspire purpose for people to live more purposefully in prevention, and in inspiring people to change behavior to embrace prevention, some of the outcomes that we've seen is that we've seen for survivors, there is improved physical wellness, there is improved mental wellness, there is improved spiritual and social wellness. They are more willing to speak out to the community. They are more willing to be reintegrated into the community to become agents of change. What this then means is that survivors themselves are taking up more action. For example, in this year, one of our survivors is training others to knit breast prosthetics, so that we put together a dignity care pack, and so that we can donate this to newly diagnosed patients, restoring dignity. We're also working with technology companies so that we can take more outreaches to the community, and so that we get more people screened as early as possible for downstaging of diseases. I welcome all of you to look at ways that you can change by A, bridging the gaps within the facility, B, exploring what gaps exist within the healthcare practice, from education through to awareness, through to timely screening, treatment, and post-treatment reintegration, but also to speak up more often so that we get more people in advocacy, we get more people identifying the challenges, and more people looking for solutions for us to be able to mitigate them. I think I will stop there so that I can welcome questions, or we can be able to have a dialogue. Thank you so much.
Thank you very much, Brenda, for that excellent presentation. And I think to all the participants, one of the common threads that is running through the presentations we've had so far is we each have a role to play. And then the aspect of collaboration. And then realizing that this is beyond today. It's more than just a one-day affair. And I like the fact that the UICC has actually put themes for each year, and just starting with a very basic discussion, realizing the problem. So thank you very much for widening the scope for us also, because many times when we look at cancer, we just think about the diagnosis and treatment. And you brought up a very important part about reintegrating the patient into reintegrating that individual back into the community. Because many times when we interact with patients, sometimes it's like life comes to a standstill and they're waiting for treatment to get finished to move on. So thank you for bringing that aspect. And then realizing that these very people who've walked this journey, as they are walking it, and even when they finish, are the people who can be the best advocates. And you're right in that a patient will listen to another patient, the community will listen to someone who's walked that journey. So thank you very much for your efforts, and also what Kilele is doing in collaboration with the hospitals and the many other people that you work with. So to take us to the next step is one of our own from Kenyatta National Hospital, a nurse who's done his training in oncology nursing, and is going to talk to us about cancer prevention. So now we are going to have Mr. Joseph Mageto. Thank you very much. Karibu sana. A reminder to all the participants, let's use the Q&A section for our questions. We are noting them down. And at the end of the last presenter, we are going to have a few minutes for the Q&A.
Good morning.
Good morning. Karibu, Mr. Joseph.
Yes, I'm not sure whether you're seeing my slides.
Yes, we are.
All right.
And your face as well. Thank you.
Thank you. This is a basic discussion, as you said, of cancer disease prevention. And we're going to talk about a few things here. On the introduction, cancer evolves over time, and when this occurs, the pathological changes that will occur may be reversible. That's why these two gentlemen, Level and Clark, 1965, came up with a 3-level model for the interventions that can be done based on the natural history of disease. And preventive strategies aim at modifying environmental and lifestyle risk factors that promote cancer. And therefore, two people, Archie and Walter, in 1971, say that the prevention strategies say that screening can alter the natural history of disease, and it has a significant influence or impact on those who are screened. So yes, I wasn't seeing my screen very well. So the slides are not moving. All right. So what are the levels of prevention we know? In this discussion, we're going to look at 3 levels of prevention, where we find the primary level of prevention. Primary prevention prevents disease from occurring. Primary prevention is done when the disease has not, the client or the person has not gotten the disease yet. And therefore, the intervention done at this level, they're going to remove the risk factors before the patient or the clients get the cancer. So primary prevention prevents the disease from occurring. And secondary prevention detects and cures the disease at the asymptomatic phase. We know at this phase, the disease, according to the natural history of disease, it's possible you could be having cancer, but it's not yet detected. So here, key is for us to do screening for early detection and treatment of the disease. And here we have to do prompt treatment once the disease is detected. But on tertiary prevention level, we're just reducing the complications of the disease. And so here we're going to look at types of clinical prevention, and I'm going to zero in mostly on the immunization and screening, but also I will mention something on behavioral and counseling. Behavioral counseling, which will lead to lifestyle changes, and also chemo prevention. So we're starting with immunization. We know that an estimated 13% of all new cancers worldwide are due to infectious diseases. Our viruses have been highlighted because they are known to increase the cancer risk through cellular transformation and disruption of the cell cycle. And here we find that viral infections will also lead to increased cell turnover, and they suppress immunity. And therefore, there is a link, a very strong link between infectious agents and cancer. So we're going to highlight a few infectious diseases and see how they are linked to cancer. So the human papilloma virus can be isolated in or detected in 99.7% of cervical cancer cases. And therefore, there are quite a number of strains. We have 40 different types of this HPV virus, but approximately 15 of them are oncogenic. And therefore, here creates a room for intervention. Hepatitis B also, HIV, and human herpes virus 8, Epstein-Barr virus, all these combined are infectious agents that can push or can put one at risk of getting cancer. And so what have we done to avert this? HPV vaccination is done to all uninfected girls or women aged 9 to 26 and boys who are potential partners aged 11 to 26 years. And therefore, we have two major vaccines available. We have the Gardasil, and we also have the Sevarix that are given at different times. But we know Sevarix can be given as a catch-up vaccination for the women who missed the opportunity. So it can be given up to 45 years of age. We also have HBV vaccination that is given to all adults that are at risk. For example, the healthcare workers. When it comes to screening, screening is done to detect abnormalities before they are clinically apparent. And therefore, the intervention that can be undertaken at that point are good because at this level, treatment is most effective. And we have different types of screening tests that can be done. Screening for HCV virus, hepatitis C virus, screening for human papilloma virus can be done also. But key that we do often is cervical dysplasia screening, where not earlier than age 21, women or asymptomatic female are checked for cervical cancer. And there are 5 different modalities that are used. We have the VIA, we have the pap smear colposcopy, and all those others are done at this level. But when it comes to screening of breast cancer, we learn that individuals who are most likely to develop breast cancer and for whom early treatment is more effective than late treatment gain the greatest value from this screening. However, not all women are screened for breast cancer. We screen those who are at risk, and there is a way to determine the risk category, especially based on their history. Here we find that clients with personal history of breast, ovarian, peritoneal, tubal cancers, or the family history of these cancers are known to be at risk. All those that have BRCA1 and 2 gene mutations, or even those who have hereditary pathogenic mutations of breast and ovarian cancer syndrome. And those that are done have received radiotherapy to their chest between age 10 and age 30. And all these others are at risk. So the risks are stratified so that not every woman can be screened. And here we find that most women fall under the average risk. And these are women who do not benefit from regular screening. And the screening modalities will not outweigh the cost and the inconveniences caused. And these are women who do not have all the risk factors that you mentioned previously. However, this group of women, when they are 40 to 49 years of age, there is something called shared decision that if they feel that they have felt they are given all the health education and therefore they decide by themselves that they need to be screened, what we call shared decision making. But also those who are 50 years, between 50 and 74 years, they are screened for breast cancer using mammography as the most preferred method of breast cancer screening. Those who are above 75 years, they're only screened if their life expectancy is wide, up to 10 years. And moving on, there are those who fall under the moderate risk. These are those who have family history of breast cancer. And this is a first degree relative. These ones also, so they need to be taken through screening processes more rigorously than the average risk. But we have another group we call the high risk. For those women who have the BRCA1 and 2 gene susceptibility, they've had irradiation to the chest, and their calculated lifetime risk is above 20%, lifetime risk of developing breast cancer. And therefore, to this group, it is appropriate that they have enhanced modalities of screening like MRI and others, and also with increased frequency. Because of time, screening for prostate cancer confers a small absolute benefit. And therefore, even in this category, we also zero in on those that are at high risk. The common screening method used is the PSA testing, which is done for this group who are 1 to 2 years. But there are those we call high risk. Average risk men are those who are now needs to be screened at the age of 50. But for the high risk are those who are carriers of BRCA genes, and especially if they are Black and they have a family history of prostate cancer. For this group, their screening will start early at the age of 40 to 45 years. If they had a family member who got prostate cancer at age less than 65 years. So there are behavioral counseling lifestyle changes that we need to look into, especially for tobacco use. And here it's because we find that tobacco use is the most important preventable cause of cancer. And it accounts to 21% of all the total cancer deaths worldwide. And therefore, what do we do in this case? We have the price regulations, advertising restrictions, time, place restriction, and smoking cessation programs. But we also have to look at other behavioral changes, especially improving the physical activities. And also, we also have to look at the benefits of physical activities, especially to adolescents, because it confers, it confers additional protection against breast cancer and colon cancer. There's also an aspect of alcohol and diet. These two are also looked into because alcohol is also known to increase the risk of multiple cancers. So finally, yes, there is the chemopreventive measures that we put in place. So the pre-exposure prophylaxis, especially for HIV/AIDS, is known to be one of the modalities, because we know that HIV was highlighted as one of the infectious diseases that can lead to the development of different types of cancers. And also treatment of hepatitis B to reduce the viral load is going to improve and prevent someone from developing a cancer of the liver. So in conclusion, there are 3 levels of disease prevention as we highlighted. We have the primary prevention, where it is the first stage for a healthy, susceptible individuals. We have the secondary prevention of disease. This is when the disease is in the subclinical pre-symptomatic stage. And we have the tertiary, whereby we now are going to measure in the clinical disease and the diminished capacity of this individual. And here we do treatment and rehabilitation. I'd like to stop there so that we end this.
Thank you very much. Thank you for leading us into the next session by highlighting the importance of screening. So as has been, as was alluded to earlier by Benda, that the cancer journey just doesn't begin at diagnosis, and you've clearly illustrated that in that there are things which are risk factors that can be addressed. And if those risk factors are identified and eliminated, that helps to start the journey of trying to reduce the chance of getting cancer. Then you've talked about screening so that we are able to detect either early or infections, especially the viral ones, which can lead to cancer later on. So to finish this first part is going to be Dr. Primas Ocheng, who's a consultant radiation oncologist working at the University of Nairobi, and actually also part of the team that's leading in terms of the training, the new training radiation oncology program that's housed at University of Nairobi, KNH. Karibu sana, Dr. Ocheng, to take us through cancer awareness and early detection. Thank you very much.
Thank you so much for this opportunity to talk to you about cancer awareness, early diagnosis, and the early signs and symptoms. So I'll go straight to the presentation because we don't have much time. So in the clinic where we sit, and almost clinic, we are seeing very young people with cancer. We know cancer has been a disease of the old, but we're seeing people around the age of 40. That's where you're getting the average for most of the patients. We're seeing even much younger patients, 24-year-old boys with colon cancer. Ask them, did your father have colon cancer? The answer is no. 18-year-old girls with epithelial ovarian cancer, which is known to occur at the median age of about 60 years. And this is worrying trend, as one of the speakers said, that we need to do research. We need to know what is going on with our cancers. In the month of January, there was a big meeting in Cairo where they talked about cancer epidemiology. And many of the oncologists expressed that many of the patients they're seeing today are actually quite young. And then people started wondering, is cancer in Africa a genetic or environment driven? Again, while the number of cancer survivors are increasing in the Western world, this is not the same in Africa. Remember, we consume a lot of data from there. We consume a lot of the treatment modalities from there. So we need to do something. We need to close the gap. And the only way we can close the gap is to know what is happening with our people. We're still losing more than 70% of our patients with cancer. So the statistic for the next 20 years is actually not very good for us in Kenya. This is from the Global Can projection that the cancer incidence is going to double come the year 2040. That's in the next 20 years. And in the same way, that doubling is also being seen in terms of mortality, that the more people we're going to diagnose with cancer, the more are going to die with cancer. And that almost like doubling. And so we need to create awareness, because we all know, as the previous presenter said, if you pick cancer early, you're able to cure it early, and it costs very little. So we must create awareness, and we must pick it early diagnosis. We must reverse the 70%, which is the number that we now see with stage 3 and stage 4 in our clinics. So cancer screening and early diagnosis is carcinogenesis, and it takes quite a time. There's a window of opportunity that we can do a lot. So healthy cells, mutations come because of genetic reasons or the risk factors. And this takes a while. It never happens in a week or months, it's years. And so these cells become abnormal. And if the cells become abnormal, then they become precancerous. And again, that takes a bit of while. After these cells become cancerous, they grow into the area where the cancer is arising from. This is the time we have an opportunity to pick. And these are people walking here and there, sitting, listening. The way we are sitting now, they have no symptom at all, but the cancer is growing in them. So these are the people we screen. These are the target population for screening. Once the cancer starts giving problems, then we now talk of early diagnosis. So these are cancer which are still restricted to where tumor is coming from. And then cancer spread. Once it's spread, we lose the battle. We can only control the symptoms, and we talk of time to lose the patient to cancer. So we have a window of opportunity that we can do a lot. And this is what people have done elsewhere and make a big difference. And actually people all over the world are doing this to try pick the cancer at this stage, abnormal cell, pre-invasive cell, and invasive cancer, early diagnosis and screening. So to do early diagnosis, there are essential elements, and these essential elements form part of the continuum of care and are highly or very, very integrated. So it's pointless to pick cancer early if you are not going to treat it. It's pointless to pick cancer early if you're not going to refer them. It's pointless to pick cancer early if you're not going to make a accurate diagnosis and scare the patient. So the first step is we must create awareness. And this is actually, we're doing well here. We're doing a lot of campaigns, and I know today there are a lot of screening going on. And every month we have been actually screening for various months which are allocated to cancer. However, access to care is still a bit of a problem, and we need to pull our socks there. So once you complete the step one, people are being aware, the community is aware, and they can access care, then we need to then screen them, pick the diagnosis when it is early, and then you then clinically evaluate and stage the patients very well. We are still doing very poorly with the cancer diagnosis. So not closing the gap. Most of the specimen that we send and get out from a pathologist, always it is immunohistochemistry is recommended. And we've seen patients waiting for diagnosis as long as 3 months. More often than not, biopsy examination takes a minimum of 10 days and can go into 2 months. We know making a diagnosis is not an easy thing, it's not a walk in the park. And then immunohistochemistry, most of it is done out of the country. And so we get a lot of delay here because this is the standard way to actually be sure this is cancer. And we've seen delays until 3 months. Referrals, we are not doing very well. This is a patient who came to me recently because they want to go to India. We offer them chemoradiotherapy for a stage 2 esophageal cancer. And the treatment was completed on the 11th of last month. They went to cardiothoracic team, and the cardiothoracic team could only offer them surgery in the year 2023, February. And so they sold properties because they believe if they went into 2023, the patient will not be there. Cancer and time is like oxygen and you. You have no oxygen, you die. You don't treat cancer in time, it kills you. So treatment, again, we have seen a lot has taken place in treatment. When I joined oncology about 2007, we treated patients with markups. And after that, there's been an explosion of technology. And now at least we are doing scans, we are doing VMAT in the country, we are doing a lot of treatment, advanced modality. And that is good for us. But the big question is, does that translate into us having more patients surviving? So access to treatment is very important. And again, the treatment must be quality. And quality of treatment must not be confused with the advanced machines. You can have a very advanced machines. If you late treatment or treat them badly or not treat them correctly, you still don't get meaningful benefit from cancer treatment. Most of our cancers that currently bringing us down are cancers which we can pick them early diagnosis, and we can also screen them. Breast, cervix, prostate, esophagus, colorectal, all are here, except esophagus. All are here. And the cancer which is killing most of our patients are also here and are all here. So we need to think out of the box and see how do we close the care gap so that most of these patients, we can pick them early. Because the biggest problem today in the sub-Sahara is late diagnosis and advanced cancers. WHO has come up with the barriers. These barriers to early diagnosis may apply to us, may not apply to us, but first is that we need to make patient be aware of the symptoms which should take them to the hospital early enough. They need also then to access care. And so poor health literacy, something I think we are doing well. I don't think we are doing very poorly. There's a lot of campaign, people on the TV, the advocacy teams are doing quite a lot of job in the community. Kenyatta, we've been going out there and talking to the people. Cancer stigma is there, but I don't think it's too a big problem, but it's there again. We must be able to reduce cancer stigma and make more and more people see cancer as a disease which can also be treated, and of course, must be done early to achieve meaningful benefit. Access to care. We know we have devolved government and we now have dispensary health centers all over the country. We're still not doing well with the cancer, so we still need to improve on the access to most of this. Some of the solution we need to look at is community involvement. We need to reduce the stigma and facilitate care. Accurate diagnosis is very important for cancer because cancer is not diagnosed by symptom or symptomatology. You need lab involved. Tissue diagnosis, we're not doing very well. We need to. So again, we need to improve our capacity to pick patients, to pick cancers. We know there have been a lot of misdiagnosis, but we can't blame anybody because cancer diagnosis is also not very easy. However, there are also NCCP is also doing quite a lot of work to sensitize or give in-service training on capacity or skill-based capacity so that the non-oncologists who actually meet these patients early enough can be able to pick diagnosis. And of course, a lot is going on here. Access to treatment, thanks to NHIF, many patients now can achieve care. I remember when I joined training 2008, Kenyatta National Hospital, all patients were paying cash and so many patients couldn't access care because they did not have the money. Again, it's also our responsibility as physicians and doctors to encourage more people to get recruited by NHIF so that we could have many patients have NHIF at the time of they get sick, because that really improves access to treatment. Of course, we have now many cancer centers where we have also done very, very well. So early warning of cancer symptoms. So cancer is like any other disease. It doesn't present as cancer. And a number of years, a couple of years ago, if you had fever that we could not know what it is, fever of known origin, the first thing we rush to is to check if you have HIV. Then TB, infectious disease, things are changing. Even cancers can present with fever we don't know, or fever of known, or just fever is the only first sign. Pains all over the body. Again, many people could mistake this with many other illnesses. Cancer can just present like that. Today, patients should not be treated for TB if they have gene expert negative, if they have ZN negative for sputum. They should be investigated thoroughly for cancer. We've seen patients who have been on anti-TB treatment, because of the major symptom was cough and all this. The diagnosis couldn't really confirm the presence of TB. So cancer needs to be checked thoroughly for that. Any blood from the body, be it in the saliva, be it from the stool, be it coughing, need to be thoroughly checked because cancer present with bleeding. Unexplained anemia is one of the things that we also see many patients present with it, weight loss, lumps in the breast or anywhere. Issues with the genitourinary, simple symptoms like issues with the urine, being paining or frequent UTIs could turn out later on to be actually cancers. Skin lesions can actually turn out to be cancer later. So the message is that if you get any symptoms which is not resolving on conventional treatment today, you need to be checked for cancer. There's a special group of patients we're seeing, young mothers who are pregnant, breast cancer, cervical cancer, and some the diagnosis is made during the puerperium. And so the midwives and obstetricians need to be sensitized that cancer doesn't choose even the pregnant young mothers could easily get cancer. Rectal bleeding is very common, and we see many of them treated as hemorrhoids, some of them treated as polyps, and some of them end up being colon cancer. Backache today should not just be treated as a backache. We see multiple myeloma with totally eaten back suddenly present with either fractured spine or cord compression, just even a prostate presenting as the first symptom, the backache. So any of these symptoms, we need to ensure that early, well investigated, and if we couldn't find the cause, we need then to investigate them and suspect cancer as well. It's a patient treated for fungal infection for almost 4 years, and then later on a biopsy was done, and it turned out to be mycosis. So simple, common illnesses like patches on the skin, which we commonly associate with other fungal infection, still could be cancer. This girl, unfortunately, was treated as for kwashiorkor. Kwashiorkor is very rare and turned out to be very advanced Wilms tumor. So the message is that cancer is common. Most symptoms, signs that we see in the hospital, if they don't improve conventional treatment, investigate and look for cancer as a differential diagnosis. So we need to close the gap of care. People fear cancers, and the fear can translate into stigma. So we need to encourage people that early diagnosis can lead to cure. People need to get the right information, so we need to go out there, talk to people, give them information about early signs, give them information about the cancer, so that if they get these signs, symptoms, they can go early to hospital. Healthy lifestyle as a benefit, early screening is a benefit, and early signs and symptoms will make us be 2 steps ahead of cancer. Thank you for listening.
Thank you very much, Dr. Ari, for that elaborate presentation. And I think the last 2 presenters have actually touched on some of the questions which have been raised, about how do we screen, how do we detect cancer early. There's a question which came in about do boys candidates for the HPV vaccination, and I'll open that to any of our panelists. And then there's also another question, is someone with a negative HPV screen but positive for other viruses, and we could clarify which ones also at increased risk for cervical cancer. Is there a way we can treat that? Thank you. So maybe either Dr. Ocheng or Dr. Nyongesa, if she's still on, can address those 2 questions. Thank you. So Dr. Ocheng, you can start us off.
Just remind me of the question. So I was closing off. Yes, the first question is on. So the first question is on if someone with HPV negative screen but positive for other viruses also an increased risk of cervical cancer, is there any way we can treat that? Yeah, so we know HIV also put patients at risk of cervical cancer because HIV reduces one's immunity, and HIV was at one time one of the viruses which were actually mentioned as AIDS fighting illness, but that changed later. So we know HIV positivity increased risk of cervical cancer in a HPV negative. And then you have both of them, then you have a much higher risk of developing cervical cancer than the normal population. The other question, do you have early detection indicator assays of possible cancer? Well, I know there's a lot of work going on in the area of liquid biopsy, liquid biopsy where you're actually looking for DNA presence in the blood to detect the presence of various cancers. At this stage, it is still being used at diagnosis. It's quite expensive. And probably with the time, they may go to detection, and then that will be able to improve. But I think there's a lot of trials going on, a lot of work going on, and actually try to have screening and early detection of cancer using liquid biopsy, but it's not yet a thing that can be used in the normal clinic or in the community.
All right. Thank you very much, Dr.
Thank you. Just to add on, Dr. There are times when we know that in our community, 99.7% of cervical cancer is caused by HPV, but it's just not HPV alone. There are other cofactors which may contribute for a person to get like cervical cancer. For example, STDs like chlamydia, infections. So it is important that one is also treated for STDs. In terms of vaccination, I've seen somebody asking whether 30 to 40 women can be vaccinated. Of course, the benefit is much higher for the preteens because they have not yet been exposed to HPV virus sexually. And those ones are the ones who draw a lot of benefit from vaccination. But older women can still get the vaccine, but they have to be screened to be sure they are negative for the HPV. Thank you.
Thank you very much, Dr. Do you want to comment on boys? There was a question about, can boys get vaccinated?
Definitely, if resources are available, even boys, it is encouraged that they get vaccination, but we know in our community, cervical cancer is the major cause of cancer death, so which is affecting women. So we see in terms of resources, preventing cervical cancer makes more sense, but I'm sure as more and more resources get allocated, boys can also be immunized against HPV, because we know that HPV can cause penile cancer, genital carcinoma, anal carcinoma in men too. Thank you.
Very much, Dr. And she has answered, I hope, for all those who raised the questions. They have been addressed. Thank you very much for participating. Sorry, we have run a little bit over time. And now I'd like to hand over to the next moderator to take us through the next sessions. You'll agree with me, we had a very good team of panelists. We've been taken through each and every aspect when we're looking at closing the cancer care gap. So thank you, and thank you to all the presenters. So now I'll invite the moderator for the next session. That's Dr. Helena Musau.
Good morning, everyone, and thank you for joining us this morning as we celebrate World Cancer Day and looking towards closing the gap in access to cancer care treatment. We know that everyone deserves cancer care, and some of the people that are disadvantaged, we tend to find are children and elderly people. This morning, we want to address the barriers affecting access to cancer care, or what we can do to close the gap regarding cancer care for the pediatric population. With us to discuss that this morning is Dr. Sarah Muma. Dr. Sarah Muma is a pediatric oncologist. She's the head of department of the oncology unit at the Kenyatta University Teaching, Research and Referral Hospital, and she will take us through that session. So thank you very much. And Sarah. Can you check if Sarah is online?
All right, we're checking from our end.
So she's now with us. So welcome, Dr. Sarah Muma, and we would like to hear, your take on the rural and urban disparities that the pediatric population experiences as we look to close the gap towards access to cancer care services.
Thank you so much, Dr. Helena. Are you able to see my screen?
Yes, we are. Maybe you can put it on the full. Yes, that's good.
Okay. Thank you for this opportunity. And I'll be discussing on pediatric oncology, looking at rural-urban disparities and how to close the cancer care gap with reference to pediatric oncology and in Kenya. Am I still on slideshow? So just by introduction, it's estimated that of childhood cancer cases over the next 30 years will be increased up to 13.7 million new cases, and 84% of these cases are expected to be in low and low middle income countries, and Kenya is, of course, amongst these countries. It's also expected that about half of these cases are going to be undiagnosed. So scaling up of cost-effective interventions in these countries stands to give us great benefits in terms of health and economic benefits by averting these needless deaths. This was a report produced by the Lancet Oncology Commission on Sustainable Care for Children with Cancer. When we look at how cancer cases are distributed, the childhood cancer cases globally from WHO and GloboCan data, in the year 2020, they showed that leukemia is the commonest cancer in most countries, as you can see. And in Kenya as well, leukemia is now the commonest cancer seen in children. And this is a sign of development. The more developed a country is, the more likely that leukemia will now be the most picked up type of cancer. And you can also see that for the rest of sub-Saharan Africa, the most common cases are non-Hodgkin's lymphoma and other solid tumors like the kidney tumors, brain and nervous system. Those become the commonest because leukemia cases are not being picked up as they should be. So this is encouraging to show that we are picking more and more cases of leukemia, which is the commonest cancer seen in children. When we look at the distribution again, low middle income countries and low income countries carry the higher burden of disease. We have between just the low middle income countries and low income countries, you have more than 100,000 of the cases, and high income countries only having slightly over 30,000 of the cases. So the majority of cases are seen in the low middle income countries. And the low number in the low income countries is more because of lack of diagnosis and patients just being missed. When we compare high income and low middle income countries, where Kenya is in the low middle income countries, if you look between the incidence and the mortality, you see that we have a high incidence and also high mortality, much higher than what is being seen in high income countries. For example, even just at the bottom for Hodgkin's lymphoma, you see that in low middle income countries, we still have mortalities, while for high income countries, they barely have any mortality for Hodgkin lymphoma. And for leukemia as well, they're having much greater survival than we are. When we come specifically to Kenya, this is the distribution that was noted in 2020. We had just about 2,200 cases of confirmed cancers in children 0 to 14 years, leukemia being the commonest at 16%. Previously, before 2018, non-Hodgkin's lymphoma used to top, and now leukemia is the top cancer picked up in children. There's a very large proportion of other cancers, and in that category, there are even patients who may have not been diagnosed or just suspected to have a malignancy, and they're classified as other cancers. So those, some of those cases could easily have been distributed into the rest of this pie chart, but many of the children may have missed being diagnosed and just remain as suspected cases. So when you're talking about comprehensive quality cancer care for children, Once a diagnosis is made, then they need to receive all these aspects of care. And that's why it's displayed it as a puzzle, which each piece fits into the other. So they should get cancer-directed treatment, whether it is surgery, radiation, chemotherapy, and then primary palliative care and psychosocial support. This is just as important because of physical, emotional, social, and spiritual distress, not only for the children, but also for their caregivers, their parents. Where it is applicable, end-of-life care and bereavement services need to be offered. And survivorship care is becoming more important as we see improvement in survival. This helps to minimize the impact of long-term and late effects of treatment. So I'll just look at each of them and discuss briefly the disparities that we see in each of those areas. So before the diagnosis, it's important to mention the challenges that are faced before even diagnosis happens. So this, I referred here to a study that looked at retinoblastoma referral pattern in Kenya. And this was done it was published in 2014, but actually the work was done between 2006 and 2007. And they looked at the referral pattern for children who had retinoblastoma and found there was a mean lag time of almost 7 months between the symptoms being seen and the patient seeking care. And also it was noted that the lowest cases were seen from northeastern and coastal regions of the country. And possibly this is because those patients would end up being referred for a very long distance where they will have to traverse to our national hospitals for treatment. And as a result of all these delays, there was a very low survival of 26%. This resulted in the formation of Kenya National Retinoblastoma Strategy. And through this strategy, networks were strengthened for ophthalmologists. There was improved awareness amongst the public and in primary healthcare facilities with the healthcare workers, improved psychosocial support. And the results of all that is that we have improved overall survival of retinoblastoma from that 26%, and probably by now maybe even approaching 60% or more. So just showing that if we look at the main issues that we have and address them directly, then we can come up with strategies that can help reduce the impact, the negative impact of these cancer diagnoses. So when you come to childhood cancer treatment, for childhood cancer treatment, there are very few centers that are offering comprehensive treatment, and this is especially in our tertiary referral hospitals. So mainly this is at Moi Teaching Referral Hospital, Kenyatta National Hospital, at KUTRRH, Kenyatta University Hospital, and a few other private facilities. We see treatment, for example, at Gertrude's and Aga Khan hospitals, and those are the main areas where treatment is offered. One challenge that is faced is that the bed capacity versus the occupancy of those same beds, you find the occupancy is 2 to 3 times the capacity that is available. And as a result, then this can cause compromise in the quality of the care that we end up offering the patients. So consideration for other treatment facilities where comprehensive services for childhood cancer treatment can be offered is one of the things that can help benefit patients, especially coming from rural areas. There's also this Wilms tumor treatment outcome study, which was actually the setting was in the western part of Kenya. And they tried to look at, despite treatment being offered, what were the treatment outcomes? And they found that about 50% of the patients had stage 2 to 3 disease, but still there was treatment failure because especially of abandonment of treatment. So even as we improve treatment in the treatment centers, there's a high rate of abandonment of treatment. And I'll just mention some of the reasons that were found for that. So when you come to primary palliative care and social support, it's been shown that there's low access, and this was from a report by UNICEF in 2013, which at that time showed that less than 1% of children who required palliative services were actually having access to these services. And that resulted in improvement and scaling up of palliative services. So we know now that that percentage has gone up. Initially, at that time, there were about 20 facilities offering palliative services, and this has gone up to even more than 70. And children, however, do not benefit as much as the adults from these same palliative care services, even with the scale-up. And some of the reasons are the perceptions of the public, of healthcare workers, and of policymakers. For example, some of the perceptions are that the palliative care services are just for end-of-life care, or just for patients with HIV and AIDS. So just removing these perceptions, whether it's been the public, amongst us healthcare workers or policymakers, can help improve the service delivery to children. There's also expansion of home-based care approach, which can also help improve the uptake of these services, so that children don't have to be traveled a long distance to go and receive the palliative care services. So some of the reasons for abandonment of treatment in Kenya, this was also a study again in Western Kenya, looking at parents' social network and experiences with hospital retention policies. And it was found that some of the reasons for abandonment were that there was hospital retention just because of bills. So parents would feel that their children have almost been imprisoned. They would feel that their children are in prison. They'd have feelings of desperation and feeling very powerless in this situation. And so at the point at which they would get a discharge, then many of those parents reported that they would not return to continue treatment. Some other reasons given for abandonment of treatment were general financial difficulties, inadequate access to health insurance. It was found that in this study, actually 54% of children who were on treatment ended up defaulting. The parents abandoned treatment, and for those reasons, financial difficulties, lack of insurance, that is NHIF, and even those who had access to NHIF, they would still drop off because of other costs. So some of the other costs would be transportation difficulties, and other things that were mentioned were attitudes of community members. For example, telling them that their children are bewitched, and especially again, the first hospital stays were a traumatic experience. So we see that even as we improve treatment services and the palliative care services in our comprehensive treatment centers, there's need to address these social factors which are causing abandonment of treatment, especially for patients traveling long distances from rural areas. So looking lastly at survivorship, it's noted that by age 50, childhood cancer survivors have experienced about 17 adverse effects, and 3 to 5 of those being severe or life-threatening, and majority of them are living with a chronic health problem. So these were just studies showing that survival in East Africa and in low middle income countries has been low, even reported to be less than 20 to 30%, but slowly coming up and approaching 50 to 60%. And also that some of the problems we see in our childhood cancer survivors are related to pain and anxiety in many of the survivors. And generally they were at risk of having adverse general health, mental health issues, and activity limitations compared to their siblings. So in conclusion, when it comes to closing the equity gaps on the ground for children, what you need to note is that in 2020, the strongest predictor of the outcome for a child with cancer was noted to be the country in which he or she is born. So in Kenya, we need health systems and models of care that are going to close the gap between evidence and practice. For example, much as we may not be able to completely pick exactly the treatment models straight from high-income countries and put them into our setup. Sometimes we need to do resource stratification. For example, modify our treatments to suit our setup, to suit what our patients are going through, and then address the issues that are specific to us, such as the challenges that our parents are facing socially and also financially. Thank you.
Thank you very much, Dr. Sarah Muma. That was quite an insightful talk, looking at, some of the challenges that we face and the things that we can be able to do to address that. Of note is we note that there are survivors, even in Kenya, where we are looking to close the gap. Despite some of the challenges we face, we do have survivors of childhood malignancies that do live to a good age and are able to continue with their life as somebody else in the normal population. Talking about survivors and survivorship, you know, we want to be able to ensure good outcomes, and that's why we're looking to close the gap. And that's the theme for this year's World Cancer Day. We want to talk to somebody who will be able to tell us, you know, what that journey has been like. And when we talk about a journey, you know, we cannot talk about it if you've not walked in somebody else's shoes. It's very difficult to know, you know, how they fit, you know, where they are actually walking. Is it flat ground? Is it muddy? Is there, you know, a bump, a valley? Have they fallen? Have they gotten up? So we need to be kind and compassionate when we're talking about survivors. Sometimes we like to call them warriors because they have conquered this great thing that we call cancer. So I think the next person to talk to us is one of the survivors. She's gone through treatment for cervical cancer, and she will be able to tell us about that journey and also some of the things that she has undergone whilst receiving treatment. So we'd like to welcome Millicent. Is Millicent online?
What I think I would really want, because we need to save that otherwise, if we still have mechanical, because mechanical obstruction will never leave a backflow, right, and we damage the pelvic system.
Maybe somebody who's moderating can check if Millicent is available.
Can we get an nephrostomy or what? Because that BFR is very low. And you think it's going to improve on dialysis?
And please keep your questions coming. We have the chat box that you can type your questions. We shall address them at the end of this session so that we can be able to talk about, you know, what challenges we're facing, how we can close this gap effectively for the rest of the country. As you're aware, this morning, there's also the launch of the Mombasa Comprehensive Cancer Center. And this is just one of the strategies that the Ministry of Health is looking to close the gap by bringing cancer services, comprehensive cancer services, closer to the people. It's one of many that is going to be launched very soon. And so we look forward to seeing more initiatives like that from our national government. Millicent is on the call as a participant, so maybe I'll just search for her and unmute her.
Yeah, I remember that lady, do something.
Right. Sorry for this technical hitch, just give us.
Those tumors don't respond very well, and a lot of the treatment is based on few cases people. I'm getting lost. I think just leave it hanging, lead around, you admit it around and see what you can do. So she can, you talk to Peter, tell her you see that you give her 1 week, and I'll look for answers here and there.
Sorry, Dr. Helena, could we allow Dr. Esther to proceed so that we allow Millicent to organize herself? If Dr. Esther is in, maybe Dr.
Yes, I think we can see Dr. Esther Mwinga, she's online. Dr. Esther Mwinga, what can I say about this lady? Esther is a coordinator for pain relief and palliative care in the Ministry of Health and seconded to the Kenya Hospices and Palliative Care Association. Pain is one of the most common symptoms that patients with cancer have. And addressing some of the symptoms that they have doesn't mean that you just address the symptom. You have to look at how best to deal with this patient because they go through many other challenges other than the symptoms that they have. They go through this treatment side effects. They go through psychosocial problems. They go through spiritual problems. And even when Dr. Muma was talking, you heard that one of the things that challenges us when we're looking at the pediatric population is abandonment. So how can we look to take care of a patient who's going through very many situations and very many things with a family that is also walking the journey with them? And maybe Dr. Esther Mwinga can help us to elucidate a little bit more on the holistic approach to be able to close this gap.
Yes,
Welcome very much, Esther. Millicent, maybe we shall give you a break and then come back to you. We shall first listen to Esther.
All right, good morning, everyone, and thanks, Dr. Helena, for that warm introduction. We'll be looking at a holistic approach to closing the quality care gap, and the previous presenters have really done a good job in terms of laying the ground of what patients do go through, as well as health workers, as we take care of patients with a cancer diagnosis. So in this sense, we'll be looking at how are we ensuring that the right to palliative care is actually achieved for these patients who are having a diagnosis that is challenging for them and for their families. So I work for an organization called Kenya Hospices and Palliative Care Association, which has a vision of quality palliative care for all in Kenya, and of course, focusing on persons living with palliative care needs who are from various regions with various diagnoses. And KEPCA works in collaboration and partnership with various stakeholders who are key in the cancer care trajectory, including the Ministry of Health. So if we think about palliative care, what comes to your mind? So this is just food for thought for us. And I've had my predecessors talk a bit about what palliative care has been defined as and what, let's say, myths and misconceptions are already out there. So the slide in front of you shows a few words and terms that came out of previous discussion with the healthcare workers. And as you can see, the patients and aspects of care, partnerships are all coming out and are all key in terms of defining palliative care. And just to let us know, in Swahili, palliative care is termed as tiba shifa. So the term on just to the right of our screen. So in case you need some translation, you're free to use that term. So palliative care is originally a Latin word, and it means to cloak. So the term pallium means to cloak. So in essence, what we are saying is we are trying to mitigate the suffering of the patient, whether or not they're receiving cure for the diagnosis that they have. So the term palliative and hospice care, we are looking at a broad aspect to care of this patient and the family. And the term hospice generally means a philosophy of care. So we are not talking about a building, and this means that this care can be provided for the patient wherever they are. The lady in the photo is the founder of the palliative and hospice movement, the late Dame Cicely Saunders, and she's very key in terms of palliative care progression to where it is right now. So in terms of the model of care that we are focusing on in terms of palliative care provision and palliative care integration is that palliative care needs to be offered from the point of diagnosis. And we've heard about the journey beginning even before the diagnosis is made. We have the screening aspects, we have the initial diagnosis. Are we getting this patient with the precancerous lesion, or do they have an invasive lesion? Have they gone into metastasis? So we are looking at all those and ensuring that even as they're going through care, as they're going through radiotherapy, whether curative or not, they're also receiving aspects of palliative care, and we look at what this entails. And then as curative treatments may diminish depending on the diagnosis, palliative care takes now full stage, and that is, remember, this is a journey and it needs a multidisciplinary team approach, not offered just by one healthcare worker. There's also post-care support where you're looking at, in case of death, is there bereavement support offered for the family which has been left behind? So the reason we are talking about palliative care is because we know our population is growing, and recent studies, including the Global Can reports, as well as our demographic studies, as well as different Ministry of Health reports, have been showing that we have an increasing number of Kenyans suffering from cancer, other NCDs, neurological diseases, injuries, violence, mental disorders. And then we also have an increasing population of the elderly who also have different complications that may need support, palliative care support. So we are dealing with a triple burden of communicable, non-communicable diseases and pandemics. So palliative care focuses on the adult, the child, and the family. So whoever is unwell, the person is at the center and the family is also supported. So the four main domains include the physical aspects. And I know the greatest complaint that will bring patients to hospital will be something related to pain and then fatigue. So they'd come and say, I've just been feeling too tired, or I have pain. So how do you manage this? Sometimes they also have the social issues. Financial burdens have been highlighted. How are we supporting them? Issues to do with roles and relationships, sexuality, appearance, and many others. Spiritual aspects are also really important, because you'll find this is when people lose their meaning of life, as well as the psychosocial issues. So palliative care aims to improve the quality of life of this patient by not just looking at the diagnosis, but looking at the patient holistically in terms of care and support. So the multidisciplinary team needs to ensure that the patient is at the center of the care, looking at doing no harm, doing the greatest good for the patient, and working as a team. So the nutritionist has his or her own strengths, the oncologist has their strength, the religious person, and any other relevant person who is key in this person's care. The WHO has approved this current aspect of quality health service and palliative care, and look at it from the point of it being a house. So you have the foundation where you have relevant health policies in place, empowered people and communities also in place, and then research guiding the provision of care that we are giving, and looking at availability of essential medicines that are used in an appropriate manner, education and training, especially for health workers, with the persons living with palliative care needs at the center of the care. So if you think of the house approach, if you remove one of the pillars, the house falls down. So as we look at bridging the gap, these are some of the essential components that we need to prioritize, even as we look at ensuring that the patient with a cancer diagnosis is receiving appropriate palliative care services. So some of the challenges that have been experienced include limited knowledge of palliative care, both by communities as well as the healthcare professionals. We have different perceptions that are not necessarily true about palliative care, including the aspect that palliative care means that you're dying. Palliative care is actually about improving the quality of life, and it's about adding life to the days of this person with a difficult diagnosis. Then the challenge of access to palliative care units and different myths about palliative care. The gaps are an opportunity for us to bridge and an opportunity for us to improve access to care. So some of the things that have already been achieved include a recognition of palliative care by the national and county governments. And currently we have over 70 centers offering care in most of the counties in Kenya. So we still have some work to do, because we would like it to be available across the 47 counties. Integration of palliative care in different core curricula, availability of standards and guidelines, as well as strategies addressing palliative care aspects, and access to oral morphine solution for management of pain. We recently had the Ministry of Health launching the first national palliative care policy that is a key instrument of guiding provision of palliative care services. It's anchored on 7 key pillars and 4 key considerations that we have prioritized, including aspects of survivorship, end-of-life care, advanced directives, and palliative care for key populations like children, prisoners, and different key persons. So palliative care provision is guided by this current document. It was launched last year in October, and currently the Ministry of Health is working on disseminating it to throughout the counties. The progress in terms of palliative care provision 20 years ago and today, there's a lot of improvement in terms of care. this recent report that was made online earlier this year looked at palliative care progress in 5 countries, including Kenya. And one of the key aspects that stood out is that palliative care and access to this care needs those key pillars that WHO talked about, as well as advocacy and empowered communities to access this care. So this care cannot be made possible if there's no financial support towards this. And our next steps would be to ensure that patients and families are not going through financial distress as they go through their cancer treatment, as they get through their palliative care. So it is possible to make it available for all in need. And as we close the care gap, we recommend that palliative care services go hand in hand with cancer provision services. And I know Kenyatta National Hospital has also been leading in this front. And I think for the next step, we'll be looking at what has actually been done at the Kenyatta National Hospital in terms of palliative care. Thank you very much.
Thank you very much, Dr. Mwinga, for that talk. And it's true, it's always a slow walk to build that bridge. And I think looking at you, KEPCA, having come up with 70 units from about, I'd say maybe 10, over 10 years ago, we can see that has been quite an improvement, and we look forward to more growth and more people being able to access palliative care services and holistic care. We are still waiting for Millicent to join us, and maybe we can invite Gladys to maybe share her experience in terms of closing the gap in terms of palliative care. We are 5 minutes over time on this session, but we will be looking to catch up. And so Gladys Mukosi, she will talk to us now and tell us, what else we can do in terms of closing the gap while looking at a holistic approach. Karibu.
Going to go straight to the presentation. And thank you, Dr. Esther Mwinga, for that elaborative speech, for showing us what we are doing in the nation about the palliative care. I'm going to just cover up on what we are doing in Kenyatta, as much as palliative care and closing the gaps is concerned. So a diagnosis of cancer begins a long journey that affects physical health, not just the person, mental well-being, and a relationship with loved ones. Just hearing the doctor say the word cancer, and I've put it in red because it is a red thing, can have a profound effect to the person. So this one was shown by Benta, and I want to show it again because I like the way she said diagnosis. We need to pick these people from the community, but the journey is long, as you can see. It is even confusing. You don't know where to start. Even when you see that, where you feel that lump when you are in the community, you don't know. They have fears. They have a lot of stigma. They have a lot of denial. They don't know whether when they come to hospital, they are going to be told they have cancer. And the journey goes on. Treatment, you don't know whether treatment is curative, it is going to be palliative. And by the end of it all, the journey stops somewhere. So we are talking about palliative care, and the palliative care concept is all about quality of life and a holistic approach. So Dr. Mwinga talked so much about the holistic care. I'm not going to dwell on this because this is the founder of the Total Pain. She's named Cicely Saunders, the founder of the hospice and palliative care way back. So we are talking about total pain, and this is all what we are talking about, the holistic care, the psychosocial aspects, the physical, the emotional, the spiritual. So what do we need? We need very effective communication skills, because when they come to us and we are not able to communicate with them, they are already shaken, they are already frightened. We are not going to help them. We need to treat the person as we destroy the cancer cells. We don't need to keep on looking at the squamous cell carcinomas. We don't need to keep on seeing the adenomas. We need also to see the Peter in this person. We also need to see the Joyce. And we need to treat the total pain in our patients. We need a multidisciplinary team, including the patient involvement. When do we ever tell the patient to be on the table to discuss their treatment or their diagnosis? Sometimes we go discuss and we come and give them without even telling them what we are doing. What about when the cancer trajectory or the cancer journey is taking another turn, as it does? Because I've seen patients who come when we are treating for intent of cure, the journey changes and the patient is now being told, treatment failure. What about when the end is near? What options do we have? Do we have an option of telling them we need this, we need to sit down and restructure again? What about the family? What is the role of the family? Do we ever involve them in decision making, or we have a family conference to tell them this journey is taking another role? Do we address their spiritual concerns, because they come when they are thinking, is this a punishment from God, or what is all this? They are trying to find meaning on what is happening with their life, because they did not expect to get cancer. So as I talked about communication, effective communication is a very core clinical skill and the foundation of excellent and successful cancer care, which we cannot avoid. You cannot just talk about chemotherapy, radiotherapy without communicating well, and it is effective communication. It's not just communication. Truth telling is one of the key elements in communication, which is one of the powerful therapeutic agents, but we still need to develop a proper understanding of its clinical pharmacology and to recognize its optimum timing and dosage. Most of the time we want to say the truth, but how to say it's very difficult. Communication is also of painful truth does not equal to distraction of hope, because sometimes we don't want to tell the patient the truth because we think we are destroying their hope. In my setting, we have this, we call it distress thermometer, which is borrowed from NCCN. And this is what we use to identify patients' distresses so that we can address them in a holistic manner. They are the practical problems. When you see this patient who is coming to you, they are also worried about their children care. When I get this cancer, who is going to take care of my family, housing, where am I going to be sleeping when I come to Kenyatta? Insurance, my NHIF is dormant, transportation, and all those things. Their family. How is my wife? Is my wife going to run away? Emotional problems, they are depressed. And the physical beings like pain, sexuality, all these things which we don't actually identify when we are taking care of our patients. So the distress thermometer is the most widely used rapid screening tool for assessing distress in people affected by cancer. And it works like a pain rating scale at the rate of 0, where there is no distress, and 10, which is extreme distress. We also need to talk about the pain, the total pain now, the physical pain. Because an estimated 1/3 or 1/2 of patients undergoing active treatment for cancer experience pain resulting from the cancer itself, its treatment, or comorbidities. Moreover, pain may continue to be a problem even when there is no longer cancer signs, because some treatment can also continue causing the patient pain, the neuropathic pains, all those which we sometimes fail to address. And remember, freedom from pain and distressing symptom is a basic right for every person. That is according to APCA. And it is also according to WHO 1990. We need to address the symptoms, other symptoms, because as we continue taking care of patients, they will cause, the treatment will cause them symptoms, nausea and vomiting and all those things. Symptoms are signposts putting up to help us make a diagnosis. But after getting the diagnosis, the patient is vomiting because of chemotherapy. Must they continue vomiting? Why can't we address those symptoms? So we also talk about dying or care of end of life. Dying is one certain thing which everyone will, we will all die at one point. Patients should be seen as individuals, not as groups, not those patients with breast cancer, and they should be asked what is important for them and involved in all decisions and about their wishes and care, even at the end of life. An opportunity to discuss advanced directives should be offered to the patients. Decisions about whether to continue with active treatment is very important because some treatments are futile to the patient. Even when we have given first line, second line chemotherapy, fourth line, we want to go even to the sixth line. I don't know whether it exists, but patients are suffering because they are getting that treatment, which is doing more harm than good. So we need to involve the patient so that we can discuss their care. What about the family? What is their role? Family members also have psychological needs, and diagnosis of life-threatening illness for a family member creates fear of losing loved ones and are concerned about suffering, or even they don't want to see their family member suffering. A study which was done on psychological distress in both patient and their family found that psychological distress of patients and their informal caregivers generally was parallel over time. Although when the patient received the treatment, caregivers experienced more distress than the patient. And we usually don't feel like our family, our patients' relatives are going through all this. I want to imagine the patients in Kenyatta and the caregivers, the way they walk up and down and all these things, and the way what they are going through. So cancer care patients lack social support. It is also another aspect which we also need to support. They lack social support, but cancer patients who lack social support have a greater desire to die. They will come and say, oh, I better die. And some also go to an extent of committing suicide. Social support can also take the form of support groups, which we embrace so much in Kenyatta Hospital and other therapies. To date, information on how or whether psychosocial care has been recognized and integrated in comprehensive cancer care internationally has been extremely limited. So we also need to consider the ethical dilemmas, ethical legal issues. Has patient given consent for the treatment? Confidentiality, when we talk about their diseases and what they are going through, even when we are doing the medical ward rounds, we are just in the open places and we are talking their private things and all that. Are we considering their ethical or their legal aspects? We also use telephone or telemedicine, which is also a good tool and which worked very well during the COVID-19 pandemic, during the crisis. And we could call the patients from all over the place and we give them direction on what to do. I cannot finish before I talk about the very successful patient navigation program in Kenyatta National Hospital, which has come to remove these gaps and also to remove some of these complications which the patients go along. We have clinical navigators who focus on helping patients understand their diagnosis, understand the plan of their treatment, and also what they are going through, and they support psychosocial support. We also have physical navigators who focus on addressing the physical movement of the patients, moving the patient from point A to B, because sometimes patients come to Kenyatta and they get lost in between there. We also have lay navigators who are the social workers who help the patients navigate through the social issues, finances, and all these aspects of care. So for us to bridge these gaps, we need to come together and rethink and take patients as a holistic person and take care of them in a holistic manner. Thank you very much, and thank you for listening.
Asante sana, Gladys, for just cementing the talk that Dr. Mwinga made and also giving us some additional information. And thank you very much for the good work that you do to close the gap and providing holistic care for the patients that we treat. We have got Millicent back online, and they always say that nothing about us without us. And who is the us? Us are the people who are going through these treatments. Us are the people who are managing to deal with some of the side effects that we get from these treatments. And us are the people who have survived and are now warriors and can be able to tell us a little bit more about the journey that they have walked. So karibu sana Millicent, and let us hear what you have to tell us this morning.
Asante sana. As you have heard, I'm Millicent Kagonga. I'm a cervical cancer survivor, and I will start with my journey because it is very important so that we can know the importance of creating more awareness in the community. So I started I got my first born at the age of 14, and I got my second born at the age of 16, my third born at the age of 20. 2010, that at the age of 20, that's where I started having the abnormal discharge. But because of lack of information, where I was living at Korogosho by then, that's I decided to keep quiet for almost 5 years, until when I saw someone talking on television about signs and symptoms of a cervical cancer, and that's when I decided to open up. Well, why I stopped for almost 5 years is because of the misinformation that I got from the community. If you are having the abnormal discharge, it is maybe a came from God, or maybe it is a curse. Maybe you have done something from God, so it is a punishment. So I decided to stop talking, because if I tell someone, I feared they will tell me it is a witchcraft, or maybe I've done something bad to God. God is punishing me. In 2015, that's when I decided to go and do my screening, and it came out positive, and I'm glad I did my treatment. And when I was told that I have cancer, I thought of a lot of things. First of all, I said, now this is the real case, because I believed that having cancer, cancer is the sickness for the rich people and not for the poor person like me here, the person who is struggling. And I had a lot of vision for my kids. So I told myself, now I want to kill my kids, my 2 kids, and then kill myself, because I saw like it is, I don't have hope. I don't have any life to live anymore. And then I lost my marriage because of cancer. Now, because of the abnormal discharge, now I'm going to lose my life, and left my kids suffering. So I went in my village, I got a gynecology, I did the biopsy, I came back to start my treatment. I did my treatment here at Kenyatta National Hospital, and I'm a testimony to tell people that we have good doctors at Kenyatta Hospital, and at our time we didn't have the navigation team, the social worker team. I don't think if I had that opportunity, but I'm glad nowadays the things are easier at the hospital, and the patient are getting the navigation, the patient are getting what they need, and they are able to ask their question. In my times, I get the help that I got from Palliative Care, and they talked to me, and I accepted myself to continue the journey. In our days, I got a lot of stigma in the community, because people didn't know much about cervical cancer. And now what needs to be done in this journey as we continue to close the gap to the cancer patient, I think the very important thing is to empower more survivors, so that we can continue, we can bring this message for the patient the way it is. I've learned that most of the parents are not like the HPV vaccine. Most of the parents are not, they don't have they have the information, yes, but they don't have someone who has gone through it and tell the person that why do you want your daughter to suffer? Like me, I was able to vaccinate my daughter, and my daughter being the first one to be vaccinated in Kenya, I wanted my daughter to live a good life. I never wanted my daughter to go through what I went through, because treating cancer is one thing, and surviving cancer is a package itself. And I can I can testify today it is not an easy journey. So I vaccinated my daughter, and I'm glad I was able to prevent or to protect my daughter from cervical cancer. So it is right time we work together in this journey. We work together as we continue creating more awareness in the community. We work together to everyone to have the information so that we can continue stopping the cancer spreading, or to give the people the right information. And we see most of the people that they are dying of cancer, it is they're coming to the hospital when they're at the late stage. And if they get the right information in the community, yes, we have the right information, but we need to have someone who has gone through the journey that we are talking, maybe a breast cancer, prostate cancer, or cervical cancer in the community, who is talking to them, so that we can create, like the statistics are telling us, more than 9 women are dying every day because of cervical cancer. But we need to change that narrative to say that more than 9 women are surviving cancer every day. And that I would be glad, because it is a work done in the community. Going through cancer, I only needed a shoulder to lean on. I only needed someone to talk to me, whereby it was very difficult, especially from the community that I came from. The community where I came from, if you are a woman and you are having abnormal discharge or you are bleeding, then you need to answer to them. Where did you go wrong? Maybe you have gone against the culture. That's why you are bleeding. But I'm glad now the message is reaching more in the community, and they're knowing if you are having abnormal bleeding or abnormal discharge, it's not a gift from God. So the key point is, let us encourage the parents to let their kids to be vaccinated, and let us empower the survivors so that they can help us in this journey to stop cancer in the community. Thank you.
Oh, amazing. Thank you very much, Millicent, for talking to us this morning. I think we always forget that what one goes through does not just involve the treatment when they're sitting in front of us as we request for tests and various investigations. You've talked about feeling abandoned. You've talked about feeling hopeless. You've talked about, wanting to end it all, but you've also talked about the strength that you got. You've talked about the good care that you got at Kenyatta National Hospital. You've talked about the staff that was there that helped to support you go through this journey. And you've talked about how you are now a victor. You're also encouraging us to talk to others and encourage others. And I'm sure you do give your talk in support groups to encourage others as they go through treatment. And we often forget that survivorship is still part of the journey in closing the gap, because there are many who come in that are newly diagnosed that do not know where to start. But if they see and hear from somebody who has gone through it, then they are more encouraged and more likely to face this fight and also conquer as you have. So that question.
Hello, please repeat the question.
So the question is about the emotional distress that cancer comes with and the need for counseling and support groups. And what is some of the feedback you've received from patients in the support groups to help to assess the impact of talking in those support groups? Are they beneficial or not?
Yes, with the emotional support that the KNH navigational team and Palliative Care they are giving out there, it is very impactful for the patient, because I have received the feedback. You feel like the patient will be telling you that maybe I wanted to commit suicide and now I'm good. I was afraid I'm going to die, because you know, when you have cancer, you at night you have those bad dreams at night. So you'll find the patient telling me that when I talked to navigation team, or when I talked to palliative care, or when I heard your story, now I'm good, I know I can overcome the situation. So that is very impactful, especially for the cancer patient.
All right. Thank you very much for that question and also the answer. We have another question looking at pediatric palliative care for those who care for children. This one is from Edna OG, and she's asking, can we have palliative care sessions for the pediatric population, and are there palliative care assessment tools tailored for children? Maybe Gladys and Esther, you can help us answer that question.
Thanks for the question. Yes, we do have tailored pediatric palliative care training available. And for health workers, there's the International Children's Palliative Care Network, that is ICPCN, that has great resources in terms of palliative care, as well as online training that one can go through. And in terms of assessment tools for children, we do have that, and the key issue is ensuring that children are also getting access to palliative care services, because most times we have been focusing on adults, and Dr. Muma has alluded to this, but you also need to prioritize these services for the children. Thank you.
Thank you very much. There was one for Dr. Sarah Muma, not necessarily linked to cancer, but talking about sickle cell anemia in the pediatric population. We know sickle cell anemia is one of those chronic illnesses. Maybe you can just tell us where treatment options are available, or where patients can seek treatments for that. Dr. Muma?
Yes, thank you for that. For sickle cell anemia, we have comprehensive services offered. We have the hematology clinic at Kenyatta National Hospital on Mondays. We also have a clinic also at Moi Teaching and Referral Hospital. And then also in areas where we have a high prevalence of sickle cell, so that's mostly in the Western region, the government facilities also have clinics offering comprehensive services for sickle cell anemia. So any of those are available.
So thank you very much for attending this session. It has been quite insightful. Remember, there is a can in cancer because we can actually beat it. And as we're looking to close the gap, we want to move on to the next session. To moderate us in this next session is Dr. Jesse Opakas. Dr. Jesse Opakas is working in Eldoret. He works at the Moi Teaching and Referral Hospital. They have now become a comprehensive cancer center. Karibu sana, Dr. Opakas, and let us keep fighting this journey.
Okay, as we wait for Dr. Opakas, I'm Roslyn. I'll carry on until he gets us. So I'll be introducing the next speaker, Dr. Irene Weru, and she's going to talk about closing the gap to cancer medicine access. She's oncology pharmacist at Kenyatta National Hospital, and she's the head of unit in clinical pharmacy. She is experienced and she's passionate about medicine access and quality care. Welcome, Dr. Weru.
Thank you so much, Roslyn, for that introduction. I was asked to speak today about sustainable care, the access to medicines, closing the gap. I'll try and not speak about issues that the other speakers will speak about, especially from NHIF and National Cancer Control Program. So I'll just look specifically at the next, at basic issues in terms of access to medicines. So universal health care can only be achieved when there is affordable access to safe, effective, and quality medicines and health products. The WHO has global targets for NCDs for 2025, and there are 9 voluntary goals. And among those 9 voluntary goals, there are 2 that are very specific to NCD medicines, where we are supposed to have at least 50% of eligible people receiving drug therapy and counseling to prevent heart attacks and strokes, and an 80% availability of affordable basic technologies and essential medicines, including generics, required to treat major NCDs in both public and private facilities. So when you look at essential medicines listings, at our institution, Kenyatta National Hospital, we are currently reviewing our hospital medicine list, and we have over 80 molecules that include antineoplastics, which are anti-cancer medicines, the conventional ones, targeted therapies, including the immune modulators and the monoclonal antibodies, hormones and anti-hormones that are mostly used for breast and prostate cancer treatment, and other adjunct medicines, including corticosteroids. And then when you look at the Kenya Essential Medicine List 2019, there are 56 molecules in the antineoplastic category. When you look at the WHO Essential Medicine List 2021, that was released towards the end of last year, we have 62 molecules in the list for anti-cancer medicines, and that includes the same things that we have said for the KNH list. So these medicines, you can see, are quite broad in terms of the number of items that you would have to manage cancer. So what does access to cancer medicines really mean? When we talk about access to medicines, this is really the ability of patients to get the medicines they need for improved health. And when we talk about access, we are looking at affordability, availability, and quality. And some of the key elements to access include rational selection. And in rational selection, we are talking about selecting those medicines that will meet the majority need of the patient. If you're looking at the bigger molecules like the monoclonal antibodies, you're looking at rational selection of biosimilars, those that will work exactly the same way as the innovator products. You're also looking at affordable prices. And I saw a question earlier from the previous session, someone asking why the cost of treatment has remained significantly high over the last couple of years. Sustainable and affordable and adequate finances is critical. And I think that's why today in this session, we are going to have NHIF speak to us about financing, because they are our major financier, especially for government facilities. And we are finally looking at reliable healthcare and supply systems. And this is what we will have in our next presentation from the National Cancer Control Program and National Cancer Institute. So what are the barriers to access? They are physical barriers. We cannot overemphasize this. The number of cancer centers is really growing, and the ministry has done a lot to really improve the number of cancer centers, but there still remains a physical barrier to access to treatment, and patients still have to travel long distances to the cancer centers. Availability of medicines remains a challenge. Some of the medicines that we have talked about as having been listed on the Kenya Essential Medicine List are not registered by the Pharmacy and Poisons Board. And as we all know, there are no local manufacturers for oncology medicines. There is limited insurance for oncology cover. And although the National Hospital Insurance Fund has done so much in the last couple of years to improve access in terms of financing, many patients still are not able to access their full treatment plan because oncology treatment remains significantly high. And then in terms of regulatory barriers, the cost of product registration is still quite high, especially for products that are required in not so large volumes. And there are lengthy registration processes. Then again, we have a free market, so the prices are really not as controlled as we would want them to be. In terms of potential solutions to mitigating the lack of access, we need to strengthen our regulatory framework. In terms of registration of products, we need to look at that. We need to look at other regulatory issues, and we have many laws that are in place, but we need to strengthen those, and we need to make sure that we are all familiar with them and that we are working within that regulatory framework. In terms of selection of medicines at institutional levels, at the national level, we need to improve on our rational selection and use of medicines. And a lot has been done, and I'll just mention that in a brief moment. We need to have policies and strengthen the systems to improve access. And to a large extent, we need to have public-private partnerships. We need to engage with manufacturers so that we can really lower the costs to the patients. And this we have seen in the last few months, where some of our innovator companies have actually lowered the prices of products and brought down the prices of products by more than 50%. We had that reduction for one of our key medicines in breast cancer management. At institutional level, one of the things that we can do at institutional level is have proper documentation strategies. For example, calculating our monthly consumption data for anti-cancer medicines and using that data for quantification so that we can also ensure that we have proper quantification and therefore availability of products when they are required. We also need to improve on our reorder levels and daily monitoring to ensure that the times of stockouts are limited. And then we need to have considerations for our markups. Oncology products are relatively high priced, especially the innovator newer products. And therefore, institutions really have to go back to the drawing board and ask ourselves, are the markups that we put on our products, do they make sense? If you put a markup, a 30% markup, for example, on a product that costs 100 shillings, the markup is not comparable to the markup that you would have when you put the same 30% on a product that costs 200,000 shillings. So those markups we will have to consider and relook at them. And then finally, I cannot complete this presentation without looking at what the pharmacists have done to close this gap. Pharmacists are members of the multidisciplinary team, whether we are talking about product management in terms of formulary inclusion, in terms of inventory management, pharmacists play that role, in terms of treatment choices and clinical care and decision making. And we also really are the ones that are at the back office compounding and making sure that products are constituted in a safe way to be administered to patients. Pharmacists manage the anti-cancer medicines as well as palliative care and supportive care medicines, including adverse drug reactions and side effect management. And what happens is that we also have pharmacists in the community level who actually on an everyday basis interact with patients and can play a key role in terms of early diagnosis for patients. Sorry, there's quite a bit of noise in the background. At Kenyatta National Hospital, the oncology pharmacy team is divided into inpatient and outpatient services. We have 4 clinical oncology pharmacists who have been trained and all trained locally at the University of Nairobi. We have 2 staff pharmacists. These are pharmacists with basic training in Bachelor of Pharmacy, and we have 5 pharmaceutical technologies. We have a team of 11 staff that are managing all our oncology products within the facility. And then pharmacists also play a key role in training and mentorship for other healthcare workers, as well as train at KNH providing the training center for the clinical pharmacy program from the University of Nairobi. We have collaborative work with institutions such as the International Cancer Institute in Eldoret and participate in training and mentorship for their facilities. And we have mentorship for upcoming cancer centers as well. And then pharmacists finally play a key role in terms of policy and decision making. And we are members of technical working groups at institution level, national, regional, as well as international level. So we are playing our role and we are happy to be part of this multidisciplinary team. Together we can close the gap. Thank you.
Thank you very much. Thank you very much, Dr. Weru, for that presentation. Indeed, we have seen a lot in terms of bridging the medicine access gap. and we can attest to it even within our facility of the achievements that have come along through the public-private partnership. Some of our patients have benefited in a big way. And maybe as we're going forward, as Dr. has challenged us, whoever has a private facility, when you're doing our markups, once we procure those drugs, let's just ensure that they are reasonable so that patients are still able to access the drugs at an affordable price and to be able to sustain it so that they complete their course. Some drugs are extremely expensive just because of the high markups. We have also understood the role of the pharmacist, and indeed we have seen lots of multidisciplinary support from the pharmacy, even within the programs we've had within our KNH system and within the national government. Thank you very much, Dr. Weru. Just put your questions on the Q&A section. We'll take them up. The next presenter is going to be Dr. Joy Frieda Chefchumba. She's a program officer, treatment, palliative care, and survivorship at the National Cancer Control Program. So she's going to take us, just in addition to what Dr. Weru talked about, progress in treatment, policies, and programs. So we're looking forward to hearing even more on what the Cancer Control Program has done to close the gap. Welcome, Dr. Joy Frieda.
Hi, everyone. Good afternoon. It's a pleasure to be part of you today. So my name is Dr. Frieda Chefchumba. I'm a pharmacist by profession, and I'm the program officer in charge of the treatment, palliative care, survivorship at the National Cancer Control Program. So I'm going to highlight the progress we've made in cancer care and treatment. So the goal of cancer care and treatment is to reduce morbidity, mortality from cancers, and to improve the quality of life of patients undergoing cancer treatment. So we all know the cancer burden. I believe the previous presenters have presented on this. In the year 2020, we had over 42,000 diagnosed cases and 27,000 deaths. And we've noticed that the effectiveness of treatment is linked to early detection. I know this is a point that we need to stress over and over. The earlier we start the treatment, the better the outcomes. And we've noticed in Kenya, over 70 to 80% of patients are diagnosed in stage 3 and 4, which definitely has poor outcomes and something we need to work on. And some of the reasons that have been brought forward for this is low awareness of symptoms, low awareness of available treatment options, low rates of acceptance of treatment, maybe due to geographical access, maybe due to cost of medicine. Then there's the low index of suspicion of healthcare workers, and this is especially for the primary healthcare workers, maybe in the rural areas. You may be seeing a patient with a condition coming back over and over, but due to the low suspicion, by the time you're referring this patient, that's when we start seeing the patient is diagnosed at stage 3 and 4. Then we have deficient diagnosis and treatment infrastructure. We've done some work on this, and I will highlight them in the next slides. Then the poor referral systems, few cancer specialists. I believe these are areas that we can all improve, but I know there's much we've done already. So on one of the areas that we've done some big milestones, according to our National Cancer Control Strategy 2017 to 2022, the strategic objective 3.1 said that we need to provide optimal treatment for those with cancer. And the activities herein include increased number of facilities providing comprehensive cancer service. So to this end, we have 11 regional cancer centers across the country. We have Meru, Nakuru, Garissa, Coast General, Embu, Nyeri, Jaramogi Oginga Odinga, Longisa, Kakamega, Machakos, and Makueni. And I've put a star on Nakuru, Garissa, and Coast, and this is why. So according to the statistics of the year 2021, You can see the facilities recorded high patient volumes, especially for Coast General, for Kakamega, for Meru, for Nakuru. And this shows that now the patient actually utilizing these regional centers, and that's a big milestone. Now they don't have to come all the way to Kenyatta, to the referral facilities, unless for the services that they cannot find on the ground. So the 3 radiotherapy facilities which are being finalized. Currently, we're in Mombasa. The radiotherapy facilities have actually been completed. They are ready to be launched. And that's a big milestone. All the patients in this area will now be able to access the radiotherapy facilities at this facility. So the other centers are Nakuru and Garissa, and they're also done. We're just hoping to launch them maybe at the end of the month. And those are, you know, it's really going to close the care gap, yeah, because now the patients in Nakuru and the neighboring counties, they're able to receive fully services at the facilities. So according to the strategic objective 3.3, also to improve capacity for cancer treatment and palliative services by providing infrastructure, equipment, and commodities. To this end, the MOH has supplied some chemotherapy to the regional centers since 2019. And currently, we're also supplying 23 essential oncology drugs. And these are going to reach the patients at no cost. They're not going to be charged for these 23 essential oncology drugs. And that's a big milestone. We're just trying to alleviate the cost of treatment to these patients and to help them not deplete their NHIF cover. Also, we have the Gleevec Access Program. We know that, as Dr. Irene mentioned, the innovator products are very expensive. So we were able to get into an access program for the past 15 years for the CML patients, and they've been receiving this medicine at Nairobi Hospital for free. And now we've been able to decentralize the services to Nakuru, Kisumu, Coast General, and MTRH. And so far, over 150 patients have been treated. So all this is also to close the care gap so that someone does not have to travel all the way to Nairobi Hospital for that service. Yeah, they can now receive it at their closest regional center. In terms of capacity building, the Ministry of Health is actually very interested in oncology training, and the funding is available to MOH and county government workers. So for further information, you can check with the Human Resource Department. Also, we've done ChemoSafe trainings for the regional centers staff, mostly the pharmacists and the nurses. And this was conducted in 2019, and we are planning to conduct another one this year. We've also conducted supply chain management training for pharmacists in October 2021, and over 22 pharmacists were trained. Another milestone in using the care gap, as we mentioned, the low index of suspicion, we came up with 2 e-learning platforms to enable the healthcare workers to just get some more information on cancer from wherever they are. And these platforms, one is called M-Saratani, and it's on Play Store. You can actually download it on your phone, and it's 12 priority cancers plus assessment. So the good thing with these platforms, it's engaging, it's self-paced. You can read it on your own and at your own pace. It's also comprehensive. We've really gone deep, as relevant as possible. And we actually consulted a lot of stakeholders in the cancer space. Even some of them are in this call. So this was a joint effort that we came up with these e-learning platforms. And on top of that, the CPD points are offered. And the overall goal that we would want to see is actually the downstaging of new cancer cases from stage 3 and 4, and to come down to maybe stage 2, where we can get better outcomes. So issues that we are addressing moving forward, financing for cancer treatment, I think that has come up a couple of times. NHIF cover needs to be more comprehensive and also needs to be tailored to the children's treatment. Also, the high cost of cancer treatment with out-of-pocket expenditure, even with NHIF cover, we've seen this. A patient just has the cover, but still being told to do a top-up, and that's something we need to address. Also, the quality and standards of care that patients receive, we need to look into that. Then there's also limited clinical trials and clinical research to inform best practice. Also, access to rehabilitative commodities and treatment-assistive devices, such as esophageal stents, colostomy bags, chemo pots. These are some of the rehabilitative items which we need to improve access. Also, in terms of cultural issues, stigma, reintegration into the society for cancer survivors. This is an area that we are also looking to do some work in. Also, we are developing the rehabilitation guidelines for children and adolescents treated for cancer. We know for children, actually, the survival rate is good if they are treated early. We've seen over 80% survival rate has been noticed in the West. So this is something that we are hoping can be replicated in our setting. So for more information on other policies that the program has developed, you can check in the Ministry of Health website. You go to resources, then downloads, you'll find a lot of materials there, including the treatment protocols, you'll find the screening guidelines, you'll find the palliative care policy that we launched last year, and other resources. So in closing, we'd like to thank all the healthcare workers for your service. We thank you for all your work in closing the care gap, and we appreciate you today as we celebrate World Cancer Day. Thank you.
Thank you for that good presentation. You've given us quite a lot of information on what the National Cancer Control Program is doing. And we appreciate your efforts, because we have seen training and capacity building indeed, and we have seen improvement in even cancer delivery because of access to the services we really need. We hope that our people will be able to take up those facilities within their reach, like the radiotherapy and the chemotherapy, and that will go a long way in improving the quality of care, because when you're able to reach the place, you are definitely able to continue and complete your treatment. So we are grateful to hear what you've done. Please keep it up. Our next presenter is Dr. Martin Mwangi. Is Dr. Martin Mwangi here? Thank you. Dr. Martin Mwangi is a specialist, and he works at the National Cancer Institute, where there's a lot of work also happening. And so we are looking forward to hearing about accreditation and designation, which is going to talk about today. I have seen Dr. Mwangi work, and he really focuses on the work so that the accreditation are done in the right way, and to ensure there is quality in the facilities that have been allowed to offer cancer care. So Dr. Mwangi, just let us all understand what you're doing at the NCI in terms of accreditation. You're welcome.
So good afternoon, everyone, and thank you, Rosaline, and the organizers of this. My name is Dr. Martin Mwangi. I work at the National Cancer Institute of Kenya, and In that institute, I lead matters around regulation and compliance. So I will just briefly take you through this and where it started and how it came to be and what we are actually doing and how our work is closing the gap in terms of cancer care. So the National Cancer Institute was born from an act of parliament. So there is a Cancer Prevention and Control Act 2012, and the act was provided so that it can look at matters of prevention, treatment, and control of cancer, and for connected purposes due to the plight and the burden that was seen that was directly associated with cancer. And I'm happy with some of the presenters who have also shown this is not about to end. We still have a journey to go through, and we need to put the right things in place. So the purpose of that act had 6 main purposes. I will only highlight the one that mainly focuses on our discussion today. And this was to promote utmost safety and universal precautions in practices and procedures that relate to the treatment of cancer. So within the purpose of that act, this was what was significant in relation to accreditation and designation. So the institute was established within the Act of Parliament of 2012 and under Section 4 of that act, whereby it clearly states that the institute shall be a corporate body with perpetual succession, a common seal, and shall in its corporate name be able to do the following. So from suing and being sued, taking and purchasing or acquiring or holding movable or immovable properties. We are able to borrow money or make investments. We are able to charge fees for services that are rendered or request for securities on the same, and also doing or performing all other acts for the proper performance of the functions of the Act of Parliament. So we have a total of 14 functions within the Institute. But our key ones that are directly related to matters around this is 1, encouraging and securing establishment of hospitals, vocational treatment and cancer centers, and other institutions for the welfare and treatment of persons with cancer in the Republic of Kenya. The other one is encourage and secure provision of diagnostic, treatment, rehabilitation, and other medical care for persons with cancer in those institutions. We are also supposed to establish and support large-scale production or distribution of specialized biological materials and other therapeutic substances for research, and set standards of safety and care for persons using such materials, and then encourage and secure the care of persons with cancer within communities and social environments. So as I said, we have 14 various functions, and these functions cut across various aspects of cancer care. But those key ones I have highlighted are the ones that are directly related to matters around regulation in cancer care. So when we talk about the accreditation and designation process, so National Cancer Institute of Kenya, in collaboration with the relevant agencies within the Ministry of Health, were able to develop guidelines for establishment of a cancer center. Now, these guidelines provide a defined minimum standard and to ensure that these standards are met. These guidelines similarly also apply to public, faith-based, and private entities across the country for anyone who has a cancer center or is intending to establish one. So the accreditation process is usually a formal process whereby the National Cancer Institute will assess and recognize a facility or an organization that meets these predetermined and published regulatory standards. Then the second phase is designating, whereby we appoint the facility a certain particular level in terms of the treatment modalities that are being provided in those facilities. So we have 3 different levels. We have a basic or essential cancer center, a mid-level cancer center, and a comprehensive cancer center. So for a basic cancer center, this is a facility that is providing at least one cancer treatment modality. And it can either be a standalone or in the premise of a hospital. So it's either providing chemotherapy, radiotherapy, or surgical oncology, only one of them. It is expected that this facility has to provide all the other necessary areas in the continuum of care. So prevention, screening, early diagnosis, early detection, diagnosis, registration for the cancer registry, treatment, palliative care, and survivorship services. So we don't just expect just the treatment modality, we expect the continuum of care to be also provided in that facility. So at the time the guidelines were being done, we were looking at the Kenya Essential Package of Health. So we were looking at a facility that is going to provide basic cancer treatment should be at level 4. However, we are aware that this is being reviewed, so this will change also within the guidelines. The next is the middle level cancer center. This one provides 2 or more cancer treatment modalities. It can be standalone or in the premise of a hospital. So they are either doing chemo and radio, or they are doing chemo and surgical oncology. So 2 or more treatment modalities. Similarly, they have to be providing all the other necessary treatment packages. So from prevention, care packages, so prevention, screening, early detection, diagnosis, registration, treatment, palliative care, survivorship. Also level 4 and above for medium level cancer center. Lastly, we have a comprehensive cancer center. So for this facility, apart from what the treatment modalities, they are providing more than 2 treatment modalities, but more to that, they are also providing highly specialized cancer services. These include comprehensive pathology services, comprehensive radiology services, comprehensive medical laboratory services, specialized surgical oncology with reconstructive surgery where need be, comprehensive radiation oncology, nuclear medicine, bone marrow transplants. They should be having an oncology training program and also an elaborate cancer research agenda. This should be a level 6 according to the Kenya Essential Package of Health. And just to emphasize, even the basic and medium level, we need to also have a cancer research agenda in those facilities. So the accreditation is just an entry-level requirement for facilities looking at regulatory standards, and these standards are optimal and achievable. The standards also are designed to encourage continuous quality improvement efforts in the facilities that have been accredited. Further to that, the accreditation is granted once we have a periodic site evaluation, and we have a team that goes to those sites. This accreditation lasts for 2 years, and every 2 years we will inspect cancer centers. And also on a quarterly basis, there will be a submission of specific reports for quality improvement when it comes to cancer care. So looking at how to, part of our efforts in closing the gap, we are trying to strengthen matters in terms of standards of service delivery when it comes to patient safety, treatment outcomes, healthcare worker safety, and ensuring that we have the right things in place. So for the inspectors, the teams that go out to inspect constitute of an oncologist, an oncology nurse, a clinical pharmacist, we have IPC specialists, we have quality assurance specialists, we have a cancer registry experts, we also have radiotherapists, we have medical physicists, we have surgeons, and we also have other members we co-opt depending on the facility that is being inspected. The procedure is simple. So if anyone wants to have their facility designated, it's a requirement that they have to request for designation from NCI. So they will write a letter of request to NCI. NCI will respond with an application form and will also attach key documents for them to review. So once they fill the application form and they attach the necessary documents, that is sent back to NCI, and NCI will review through the Regulation Advisory Committee. Once they have reviewed, a team will be sent to do the inspection. We are working also with KNH-UoN, the medical board. So we have the team of inspectors who will go to the facility. They will visit the facility, they will visit the service areas, they will look at what is available in the facility in reference to the recommended standards. Then they will have a discussion with the facility and the team in the facility, share their findings and their recommendations, and have an agreed decision at that point there in the facility. And after that, a report will be shared with the facility. An official report will be shared with the facility 72 hours after the inspection. If the facility has met the minimum requirements, a final approval is provided by NCI Kenya, and the certification is provided on the same. Where an application may be rejected or a facility is not compliant, a detailed report is provided on the same. This is the facility scoring and criteria. So we have a fully compliant, and it's color-coded. It's a fully compliant facility. The risk category is low. The compliance category is they have scored above 75% of the scoring from the standard checklist, which I will show later. And there, the facility is provided the required licensure for 2 years. We are also working with NHIF and other partners, so such facilities are also referred or recommended to NHIF and the other partners we are working with. And if there are any incentives that are coming from NCI, such facilities are considered in those incentives. Then we have partially compliant. This is medium risk. They score between 41% to 75%. So there is a time period of 1 to 12 months whereby they have a chance to do any remedial recommendations or reinspection can be done. And where you find the facility needs to be reclassified during this period, it will be reclassified, and then the cancer center can request for reinspection and categorization within that 1 to 12 months. For non-compliant, they are considered high risk. They have less than 40% scoring during the inspection. Such facilities, we recommend closure. We also recommend the management to reconsider and reevaluate the need of the cancer center and its investment in that. And where they do not have any prerequisite registration, licensure, and required, then the last result will be issues around prosecution. I think at this juncture, I would like to mention that we as an institute cannot inspect a facility that does not have a medical board license, does not have the KMLTTB, the lab license, the PPB license, or even the Kenya Nuclear Regulatory License. Just for information's sake, these are the charges. We usually charge for licensing, facility licensing or redesignation is 5,000. This is a non-refundable fee that the facility pays. For facility inspection, this is a fee payable to NCI for performing an inspection for designation of a cancer center. For basic is only 20,000. For middle level is 25,000. For comprehensive, it's 50,000. For designation, this is a fee that is paid to NCI, and it's paid after every 2 years, and you pay 25,000 for basic, middle level 25,000, and comprehensive 50,000. Please note, if a facility requires to be redesignated, it was a basic cancer center and has increased services and wants to become a mid-level cancer center, they will undergo the prescribed process as I have earlier mentioned. So they will make an application, it will be reviewed, a team will be sent to inspect. In summary, what are we doing as an institute to close the gap? First of all, we have inspected over 30 cancer centers in 14 counties. And we have only accredited 25 cancer centers. So we are really pushing the button on people having the minimum standards for cancer care treatment within the country, as we also work in other areas to make sure that there is cancer prevention. There is also matters around screening and early diagnosis. In terms of partnering, we have partnered with key partners to make sure that we improve delivery of standardized care, from KEPCA to NHIF to American Cancer Institute and so on. We have also developed the National Quality Management Framework around cancer, and this is currently under review and will soon be launched. Then we are also strengthening capacity building, and here we are working with the National Cancer Control Program, whereby they will be able to strengthen matters around primary health care, as we also look at partnerships for specialized care for our healthcare workers who want to do specialized care around oncology. So partnering with universities across Kenya and also outside the country. We are also using research to improve and strengthen oncology services and service delivery. So we are also working on having grants and also proposals, try to see how the research partners like Cambridge, we can work with them to be able to bring research on board to improve oncology services. I am happy to also say we have developed the National Cancer Registry. I think currently we have over 30,000 cases already uploaded into the Cancer Registry, the NACARE system, and it is also work in progress. We are hoping to also disseminate and showcase what is there when it comes to matters around the National Cancer Registry. So the application form looks like that. So this form is filled and sent back to us with the necessary attached documents, from the licenses to professional practice registrations, retention certificates, display, design plans, waste disposal plans, and so on. This is a standard checklist that we use. The checklist looks at physical infrastructure, equipment, human resource, operational considerations in the various service areas, SOPs, treatment protocols, and so on. And then this is a certificate that is issued to the facility that has met the minimum standards. Just to show you what we have found on ground, you can see this is in regards to chemo mixing, and you can see the recommended standard is either class 2B and above. You can see there that facility had a class 3. On my right, you can see other, we don't have classes for this, but these are some of the other chemo mixing areas that some facilities have had. When we come to cancer registry, you can see the standard and elaborate cancer registry within a facility with proper filing, proper files, and even with computers and internet. On my right, you can see files being kept with specimen, blood specimen, and other specimens. And this is a filing area for that facility as their cancer registry. So I want to thank you. If there are any questions, I will respond. Thank you very much.
Thank you very much, Dr. Mwangi. Indeed, you have given us highlights about National Cancer Institute and more so on the role of accreditation. So we would, from this presentation, it is important that if we have a facility that is coming up or that we know of, we try and link them up with the National Cancer Institute for accreditation. And so don't shy off from being found not to be doing the right thing, as you have seen the ideal from the photo and the ones that are wrong. I even saw a biosafety cabinet that looked like something for keeping chips when they're being sold, and that is quite substandard. So it is our role to advocate that the people who are offering services are doing the right thing, and so we link them up with the National Cancer Institute, because I'm sure that those who do not meet standards are given supportive care, supportive supervision, until they're also guided to know how to rearrange maybe the facility and what else they need to procure so that quality is attained. So we are looking forward to the Q&A, just a bit of Q&A after our last presenter. And the last presenter is Mrs. Judy Otele. She comes from National Hospital and Insurance Fund, or rather NHIF, and she's a Senior Benefits Management Officer. So she's going to talk to us about bridging the financial gap through NHIF. Please hold on and let's have an interactive session so that we can be able to advise our patients appropriately. You're welcome, Mrs. Judy Otele. We are not able to see your presentation. Good afternoon.
Good afternoon to you. I'm trying to share my presentation.
The soil of as far as I'm concerned, the soil of my motherland is even more pure than the sand. And this souvenir is always going to remind me that I have an obligation. And that obligation is that I always have to protect the soil.
Just a moment. Good afternoon. Let me try and share my presentation in a moment. Hello, can you appreciate my presentation?
Thank you very much.
Good afternoon.
Just make to come on a slideshow if possible.
Good afternoon. Thank you. My name is Judith Otele, and I'm not the Senior Benefits Officer. I'm a Manager Case Management at NHIF, and I'll be sharing with you what NHIF is doing to bridge the gap in oncology care. And as NHIF is a financing institution, our bridging the gap is mostly financial bridging of the gap. So thank you so much. So just as an overview, NHIF came into being in 1966 as a department in the Ministry of Health, and we have evolved to become an autonomous health financing parastatal in Kenya. And a lot has happened in that evolvement, from just being able to cover people in employment under the public service to include voluntary contributors. And the operating environment, as all of us are aware, is also evolving with the review of the NHIF Act 2022, which was accented to by the President a few years ago. And we are now in the process of formulating regulation to dictate how members and providers are going to be engaging with NHIF. Our mission is to contribute towards UHC in the provision of affordable, accessible, sustainable, and quality health insurance through strategic resource pooling and healthcare purchasing. And our vision is to be a world-class universal social health insurer. So the functions of NHIF, as in the previous act, and which are also going to be enforced in the current revised act, is to register and receive contributions, register members and receive contribution from members, make payments out of fund, that is pay claims to declared hospitals, set criteria for declaration of hospitals so that we can recognize them. And towards this, we are working with a lot of regulatory bodies, from the Kenya Medical Practitioner and Dentist Council, the NCI, as Dr. Mwangi has said, the medical labs, the Pharmacy and Poisons Board, and other bodies that are involved in declaration of facilities. Our other function is to regulate contributions payable to the fund and benefits that we can make from the fund. And of course, protect the interest of contributors to the fund, because NHIF is a contributory fund. It's a members fund with no finances being received from the exchequer. So being a members fund, we have to protect the interest of contributors and advise government on national policy regarding health insurance. Those are our functions. And then this is how we have evolved, and I've already talked about this. From 1965 up to 1972, we were just concentrating with public servants and taking care of their daily per diems in hospitals. Then from 1972, involuntary contributors were allowed to make contributions to NHIF. And in 1998, we were established as a corporate institution, and the NHIF Act of 1998. Then from 2012, NHIF stopped just being a social insurance, and we were allowed to have an enhanced or a commercial arm by being recognized to offer an enhanced scheme for civil servants and discipline services then. And from that time, a lot of other developments have taken place. It is during that period that premiums were increased from the maximum of 320 for the ones who are employed to a maximum of 1,700. And the self-employed used to pay 160, which was reviewed to 500 shillings per month per family. And other flagship programs that came into being include the Linda Mama, the Health Insurance Subsidy Program, and the insurances that targeted the vulnerable, the indigents in Kenya. And in 2015, again, because of increased premiums that members were contributed, we were able to increase our benefit packages from the initial per diem, which we used to be called the bed rebate, to have packages that are expanding by the day as we try to meet what the market trends are and what the feedback from beneficiaries and our members is. And then in 2018, in a run-up to UHC scaling up, there was a committee that was formed by the ministry, the CS Health, called the HEVREP, which was to recommend how NHIF would be repositioned as a strategic purchaser for benefits and a driver towards attainment of UHC. And from 2020, our focus has been in the scale up of UHC, which is actually being launched on Monday by His Excellency the President, and for which NHIF has been identified as a driver. So that's a small synopsis of how we've developed through the lifespan. And in terms of access, NHIF prides itself as having 156 service points countrywide, with 70 branches, that's a 3 satellite office and 53 Huduma centers. We also pride ourselves in adapting to technological evolution. And the latest things is that you're able to register yourself online, you are able to pay your contributions online, you are able to ask questions and also monitor how your contributions or your card is being used by yourselves and your family electronically. And then we've also established a state-of-the-art call center to also respond to our beneficiaries' demands and to set the standard as a world-class health insurance. As it is now, NHIF prides itself as having a network of 7,666 healthcare providers who are divided, as you can see in the slide. Majority of our healthcare providers are government facilities. Of course, being a government institution, we are very keen to ensure that all government facilities are recognized by NHIF to provide services. We have 1,524 private healthcare providers and 311 faith-based providers who are distributed countrywide. So currently, the benefit packages that are available for all NHIF beneficiaries, whether you are in the enhanced scheme or in the national scheme. A national scheme is the people who contribute voluntarily and those who contribute statutorily, but are in the private sector, not in the public sector. And what is available for these contributors for as low as 150,000 per month per family to 1,700 per month per family. Those benefit packages: outpatient cover, radiology, inpatient cover, emergency evacuation, maternity cover, overseas treatment, oncology services, surgical services, dialysis services, and mental and behavioral health services. So those are benefits that members and beneficiaries can access by being NHIF contributors. So what is NHIF doing in closing the oncology care access gap? We understand that an effective response to cancer treatment requires strengthening of health system functions, and it requires stewardship and financing, service provision, service delivery, and resource generation. And we are involved one way or another in this because of the functions that we looked at the beginning of the presentation. And as Dr. Mwangi said, we are working with them to ensure even service delivery is in an environment that is conducive and that promotes recovery and well-being of the patients. Resource generation for now basically is through pooling of resources through contributions that members contribute to us. And this is actually being enhanced by the new act, the revised act, which now makes NHIF contributions obligatory for any person aged 18 years and above, and which also is calling upon employers to match what employees are contributing without having to reduce this from the payslip. So employer matching of contribution is one way. We are also trying to ensure resources are generated so that the perennial complaints that NHIF package is not adequate can be resolved and people can have more comprehensive access to oncology and allied healthcare services. So most presenters have talked about barriers to oncology services, and I am not going to belabor on that again, but for us, the most important barrier as NHIF is the cost of testing and treatment, and of course, access to financial help for beneficiaries who need this care. That is the greatest barrier, and that is our focus as NHIF. Of course, we also want to ensure we are financing quality oncology services, and access is also important for us. There is a lot of paucity in oncology treatment centers. There are very few. And so as a result, apart from the direct costs related to access to treatment, we have the indirect cost of transportation, accommodation, lost man hours, and the like, which are also impacting negatively on compliance to care and access to care. So one of the presenter, I think, already talked about the impact, the financial impact of a cancer diagnosis to individuals, to families, to communities, to the country, to societies. And as I've said before, financial barrier is one of the most important barrier to access because it can actually be whether the culture, and when we have adjusted for culture and other barriers, financial barrier is very difficult to adjust for, and cancer diagnosis has been shown to plunge families into catastrophic expenses and poverty within a very short span of time. And studies have shown that 68% of families facing cancer experience financial hardships. No one is rich enough to be able to finance a cancer diagnosis. And as a result of that impact, 55% of patients' recovery is negatively impacted by financial stress, and 46% of patients who experience oncology-related financial burden cut on other necessary expenses, such as food, school fees, so as to pay for treatment. And more than 6% of people or families that have a cancer diagnosis have to sell their assets as a result of that diagnosis to be able to afford care. So the cost of health generally is a growing international concern, but the cost of cancer management is even of a great concern because unfortunately the products and the diagnostic services related to cancer are unique and very expensive. And the doctrine of a fair price in cancer does not seem to hold. For surgeries and other services, at least you can even get them, they can be delayed And for medicines, you can buy them over the counter from the pharmacy. But for cancer treatment, we need huge financial investment. And as a result, cancer treatment is very expensive. So I'm not going to belabor this. We are going to be sharing these slides with the team. And it's just a reinforcement of what previous speakers have spoken about cancer. And so, but of importance is to understand that lack of insurance, insurance is a great way of ensuring that shocks related to catastrophic expenses in oncology care are handled. Unfortunately, 1 in 4, a lot of Kenyans and a lot of Africans and do not subscribe to health insurance, either due to social, cultural, and economic factors. And as a result, because cancer treatment is expensive, sometimes this could delay diagnosis, it could delay decision-making, even when a cancer diagnosis has been made. Because I know one of the clerking question nowadays, even for doctors who are in this group and who are listening, is one of the questions we used to ask your name, where you come from, education status. A question that has been added in that family social history and economic history is, do you have an NHIF card? And so what we are finding is that a lot of people are subscribing to NHIF when a diagnosis has already been made. The card takes up to 60 days to mature, which is valuable time to start intervention. And so sometimes a cancer that was in stage 1 can quickly turn to stage 2 by the time intervention is being initiated. And so, and we are hoping that the new act, which obligates everyone to pay, will actually eliminate such a scenario, so that everybody, by the time a cancer diagnosis is made, the treatment can be initiated at that point. The other impact, financial impact, which is indirect as a result of cancer diagnosis, is that caregivers may lose their savings and may also lose employment as a result of taking too much time away from employment to take care of a loved one when they are going through cancer treatment. Yeah. So we've already looked at that, and the major costs in oncology as a result of drugs, diagnostics, surveillance, and related services. Of course, human resource training, a clinician for cancer as a specialist in cancer treatment is also very expensive. And so the investment in cancer is huge, from the times we are talking about human resource to infrastructure to management. It is actually just huge financial burden. And these are the impacts of not having a cancer diagnosis financially. As I say, that is going to is our focus more. And it has been shown that people who have no insurance or have low socioeconomic statuses have a late diagnosis, are lost to follow-up, default treatment, get less care during hospitalization, are likely to receive less costly procedures, have higher in-hospital mortality rates because probably of rate presentation, probably because of also other support factors like good nutrition, good housing, that are important factors in influencing health, and health-seeking behaviors may also be compromised due to poor socioeconomic statuses. So how did NHIF start financing oncology services? Up until 2016, as I said, NHIF was known as a bed. NHIF card was known as cardiac kitanda, but from 2016, we started listening to beneficiaries and members. And one of the reasons why we started listening is because we were receiving a lot of appeals in relation to hospital bills, especially from patients or Kenyans who had a cancer diagnosis in the family. And as a result, and responding to that, we came up with an oncology package, which was very basic in the beginning, and which continues to grow and evolve as we learn lessons and as people become aware, and as diagnosis becomes better, and as investment in cancer management also becomes better. So NHIF is evolving the oncology package to be able to respond to the changes in the operating environment and changes in members' needs and wants. And so we also understand that we cannot be talking about UHC attainment if we do not have adequate access to quality and affordable oncology care services. So we can only talk about UHC if members and Kenyans can have access to quality and affordable access to services, including oncology services. So how does the oncology package look like? Right now, the oncology package takes care of radiotherapy, brachytherapy, and radioiodine. They have been classified into like, needs to be more of a radio related therapies. So we have radiotherapy, brachytherapy, and radioiodine, which we are covering for both enhanced scheme beneficiaries and national scheme beneficiaries. And we understand that probably at this point in time, our coverage may not be adequate to satisfy the needs of cancer patients, but we are working towards ensuring that the care plans can be financed. And we think the new act is a win for us because it's going to increase the revenue base. And so we are going to be able to cover more for the oncology patients. So the next, we have also chemotherapy, which covers first line, second and third line chemotherapies. Again, we are still talking about cycles because the financial resources that we have may not be adequate to cover the whole care plan, but we are hoping that the new act, the revised act, will be a game changer in this so that we can finance care plans as prescribed by the oncologists. Then we have oncology support packages, which include imaging, like we have MRI, which we cover, CT scans, which we cover, PET scans, which we cover. The new contract that was supposed to start in July, we have also factored NM scans to be covered for all cancer patients who may require them, whether they're in the national scheme or in the enhanced scheme. So that is a new addition to the oncology care services for the new contract and for the oncology patients. The other surgical package, we also is a support service for a support package for oncology, and we cover biopsies, we cover debulking or where that is required, we cover excisions of tumors, and we also cover supportive care like nephrostomies, PEGs, and other surgical interventions that a cancer or an oncology patient may require. We have dialysis package, which is a support package for cancer. It may not be directly cancer related, but at least if a patient has prostate, cervix, or they have had radiotherapy that may have resulted in acute kidney injury, we will cover patients for dialysis up to 3 sessions per week. Then we have overseas treatment, which we cover for oncology services that are not locally available, including bone marrow transplant, organ transplant, some surgical interventions that may require more advanced approaches like cyberknife or robotic, some forms of chemotherapies that are not very well advanced locally, including some immunotherapy interventions, and of course, some of the PET scans that may not be locally available. NHIF is covering that for beneficiaries as a way to reduce the financial gap in oncology services. Just to mention, all oncology services are subject to pre-authorization by NHIF. And what I'm displaying there is the pre-authorization process. My urge is to all oncologists and people working in hospitals to ensure that this is done well in advance, because most oncology services are planned. And so if the requests are sent early, they will be taken care of early enough to ensure continuum of care for the patients. So in conclusion, and what are we taking home? There cannot be UHC attainment without access to affordable quality oncology services, access to quality cancer care costs, and even if a patient is not paying for it, someone else is paying for it. It's not free, even where it has been labeled as such, it is not free. And the cost of cancer care involves costs that are related to training, human resource for health, oncologists and allied clinicians. And because also oncology care is highly evolving, the oncologists and other clinicians have to keep abreast with what is happening. So there needs to be a lot of financial investment in ensuring the human resource is apprised about what is happening and abreast with what is happening. Again, there is finances related to the infrastructure and health technology assessment, which again is evolving very fast. Of course, commodities as supplies are very expensive. The licenses, including what Dr. Mwangi has just told us. So there are a lot of finances involved in setting up an oncology center, but also not only in setting up an oncology center, but also patients accessing oncology care. So towards this, there needs to be a concerted effort in pooling resources. We need higher investment and advocacy, and some of the advocacy efforts should be towards zero rating oncology products and ensuring, as one of the doctors said, that the markups in oncology products and services are regulated and are lower. And as NHIF, from 1st July 2021 to 31st December 2021, 6 months, we spent over 1 billion for direct cancer management. That is for chemotherapy, radiotherapy, and chemotherapy and radiotherapy and PET scan. And we spent another $500 million for support services, including surgeries, including dialysis and the like. We understand that the current financial coverage by NHIF is deficient. It is a fact. We would want to cover the whole care plan, and we are hopeful that the obligatory contribution envisioned in the revised act will increase revenue base and enable NHIF to expand the coverage so that members do not have to go back to their pockets to finance oncology services. So thank you very much. That is how NHIF is contributing to bridging the gap in oncology care. Thank you.
Thank you, Mrs. Judy Otele, for giving us quite elaborate information on what NHIF is doing and what it has done. And indeed, personally, I've seen a lot of transformation in cancer care. Since 2016, we have now people able to afford the treatment and even consistently be available to complete their treatment despite the other barriers we mentioned. So we are grateful for the efforts. I saw quite a number of questions on the NHIF. of which some of them you answered a long way, like availability of certain packages and even some diagnostics procedures and even staging, like MRIs and CT scans. So I've had you answer them along the way. There's only one concern that maybe one day if you get an opportunity, you can talk about if it's coming in the new package or would wait for it, is in terms of screening to avoid the late stage diagnosis so that people can be able to know that if I walk in, I'll be able to have a mammogram done. If I walk in, I'll be able to have an HPV DNA done through NHIF. So then we get to even cut the costs of treatment, which is even quite expensive. Otherwise, we are grateful as healthcare workers who are serving these patients because of your efforts. And to this end, if I'm asking you people to allow me to close this today because the questions are many, but we cannot respond to them all. You will be getting notes on the KNH website just to give you some highlights in case you missed out. So with this, I will request Mrs. Divina Nyarera, the nurse manager CTC, to close for us. You're welcome.
Good afternoon, good people. I think it is the best way to have celebrated the World Cancer Day, to share knowledge, to share experiences on how you've taken care of the patients. And from my end, I will only appreciate you. I also appreciate the organizers of this workshop. I think it was properly organized. I liked the multidisciplinary approaches that were able even to listen to the insurer. That was excellent. We appreciate that. I also want to appreciate the presentations and the presenters for making time to come and share the knowledge and experience. That was very, very interactive. And it was knowledge rich, I can tell you. And I am sure we are not coming out as we came, but we are going out with a lot of knowledge. I appreciate all of you. I also want to appreciate the attendees. It is very encouraging to see over 600 people attending. And I think this is very overwhelming. And we appreciate, and this tells us that the knowledge has actually been passed. And the attendees are from different parts of Kenya, which is also very encouraging because this means our patients, wherever they are going to be taken care of with the knowledge that we have actually gained. And with this knowledge, it tells us that we are actually ready now to bridge the care gap in terms of cancer care, and also to optimize on patient experience as we take care of them. Because from now then we mean we'll look at the patients in a patient-centered approach, and then we can be able to now tell how do we listen to the patients before we start giving them the medications. So thank you very much. I want to appreciate all of you. Have a nice afternoon and a weekend ahead. And we look forward for more interactions in the future. Thank you very much.
It's not that we are lazy. The idea here is not that we are not knowledgeable. It is the change of attitude. It is the change of attitude. We want capabilities that will enable us to change from this third world economy to first class economy in 10 years as they've done in other countries.
And succeeded with the
That was a good way of marking World Cancer Day. I'm sure we are all logging out, and even as you log out, let's have a look at our screen. There's a session coming up next week, a very important one. Let's share. It's about integrative PrEP and sexual reproductive health services. We have very good speakers aligned for us, and definitely something we want to share with all the young people and the old alike, because this is something that affects us all. See you on 10th of February at 2 p.m. again on this website.